Hey everyone, this is Victor from Cyborg for Life, and I want to welcome you to episode 100 of Limb Lengthening Live, where the patients interview the guests. And today we
Okay,
have a
so
very special guest, Joy. With
it's only Sebastian and Danielle.
sorry about that, guys. Had to mute her. Where the patients interview the guests, and today we have a very special guest joining us. He is a world-class limb lengthening and deformity reconstruction surgeon who has thousands of successful surgeries under his belt. Not only that, but he's also the reason why the Limb Lengthening Live podcast series is where it is today. That's right. He helped us kick off episode 1, and now he's back to do episode 100 in today's awesome presentation. So, without further ado, hailing in from the Paley Institute in West Palm Beach, Florida, ladies and gentlemen, allow me to introduce you to the best limb lengthening surgeon in the world, Dr. Craig Robbins. Welcome.
Thank you, Victor, for your very kind words. It's pretty amazing, 100 episodes already. It seems like we just started talking a couple of weeks ago, and here we are. So congratulations on that, for getting your good information out. And it's kind of exciting to come back where it all started. So thanks for having me.
Yeah, absolutely, man. You have helped us tremendously for this huge monumental milestone. But, I'm super pumped to have you here, Dr. Robbins, but we're not alone. We have some of your patients here from the Paley Institute, but we're going to get to them in a little while. So let's go ahead and kick off this show. So first off, we're going to go ahead and go through the agenda. I'm going to pull up a presentation that I have here. Today's topic is limb lengthening horizons, technologies, and techniques with Dr. Craig Robbins for the Paley Orthopedic and Spine Institute in West Palm Beach, Florida. So the intro is we're going to go over who Dr. Robbins is for those of you who are new here. Then we're going to talk about the topic of today, which is the technologies and techniques, as well as some tips that Dr. Robbins has from his orthopedic practice over the years. Then we have some submitted patient questions from some of you who have actually emailed me or put them into the communities. Then we're going to talk about the Paley Institute and why it's one of the best clinics in the world. In fact, it is the best clinic in the world. It's the most experienced. And then we're going to do an open live Q&A to all you patients watching around the world. So without further ado, let's go ahead and get the process started. So Dr. Robbins, I mentioned it at the beginning. He's a world-class surgeon, has done surgeries all over the world, talks all over the world, but he also works next to the most experienced limb lengthening surgeon in the world, Dr. Dror Paley. So I want to get a take from you, Dr. Robbins. What is it like working next to a legendary surgeon like Dr. Paley? What did it help you hone your orthopedic skills over the years more than it already is? Yeah.
Yeah. So you've heard me say it, and I have no problem saying it again. I've been doing this for 18 or 19 years, whatever. I finished training in 2005, however long ago that is. And I go to work and I still learn every day. Part of it is just, I think me, and when I say me, I mean all the other people on our team. He selected us because of what we bring to the table and who we are as individuals and as surgeons and clinicians. But all of us have that own internal drive to be better and hone our craft more. And it's nice to say that after this long, I still learn things every day from doing what we do. And I'm a better surgeon today than I was 10 years ago. And let's hope 10 years I'm even a better surgeon. Just from experience and the breadth of pathology and where our patients come from. But I remember, so for people who are in the medical community and know the name Paley, or patients who have met him or are excited by his name and what he brings to the table, that was me in 2002. I was a resident in New Orleans. I got the bug to do pediatric orthopedics. And I remember distinctly walking up to him at a meeting and introducing myself and say, hey, I want to learn from you. A month later, I got an email from one of his administrators. And 2 years later, I was doing my fellowship with him. And here we are. So I am my nine and a half years with him. I was in private practice for 9 and university for 9 years total. And then I've been 9 years with him. And I don't know, it's pretty amazing.
Definitely is. Dr. Paley is definitely a myth, but you are here right now. So I know you've been all around the world this past year doing lectures from, I think you told me, Brazil, and then just recently Germany to give talks on limb lengthening. So what were your focus when you were at these events?
So a nice thing about the institute we're at, even though we are not technically a teaching hospital like you would think of a university with residents and medical students, we are an educational higher learning institute because we publish our research, we publish our results, we think we're great, but we also try to show we're great by our results. It's not us just saying we are because we think we are. So we do a lot of research, considering we're not considered an academic institution like a university affiliated with a major teaching center. So as a result of who we are and the good work we do, we get invited by various institutions to come share our knowledge. And whether you're in the stature side of this, which is a very small niche practice, or you're in the pediatric reconstructive side of this, which is small but still bigger, or you're in the adult trauma reconstruction, all of which I do, there's global communities, especially now with Zoom and teleconferencing. The world is a much smaller place than even 15 years ago. So it's always nicer, I think, to go in person, because you get to talk behind the scenes and you get to interact face to face and share cases standing by the water cooler between meetings. But it's nice. I'm very privileged and humbled to be invited to these meetings. Whenever I can, I go, just to spread the word of the good work we're doing and learn. I was in the German meeting, and they were talking about doing some really cool bifocal, whatever fancy word, transport for bone lengthening, distraction for trauma reconstruction. I was like, that was really cool. It's something I hadn't seen before. So yeah, I've been personally in Brazil. I've been personally in Germany. I just lectured in Japan. I did a virtual in Uruguay. I did a virtual in Argentina. It's really very cool.
That sounds like it's super cool, man. You're all around the world spreading the good word about limb lengthening from the best clinic in the world. So that's amazing. Now, I mean, we know you spend a ton of time in the OR, in clinic, checking up on your patients. I mean, you were just doing it backstage. That's why we were a little bit late, because you wanted to follow up with your former patients here. That's incredible. But, you're also a husband and a father to these amazing, like, I guess, athlete phenoms over here. So talk about the family, man.
So always family first, right? So you put on your work pants and you go to work and you do your thing, but you come home and it's the people you surround yourself with who help you decompress and get through the day and the stress of the things you do. And I am so fortunate to have amazing kids, an amazing wife, amazing siblings, and really, Victor, my life is so blessed. And I think it comes with wisdom, reading glasses, balding, gray hair, is you learn to appreciate the things you have, and there is no greener grass. I am really, really, really fortunate to be in the place I am, surrounded by great people, not just at home, but my work family too. You see your work people more than you see your home family, and really, truly surrounded by excellent people. So thanks for asking.
No, definitely. And before we go on leisure activity and fun, I know you, Dr. Paley's into biking and now picking up pickleball. But what are you? I think you mentioned working out at one point. What do you?
Yes. You can't tell by looking, but in my former previous life, I was a pretty avid triathlete. Not sure if you remember, if you know, about 2.5 years ago, I had a pretty significant wrist reconstruction. So I'm 100% functional working, but doing some of the outdoor activities I used to like, I'm a little hesitant to do it. I was a very skilled canyoneer, so a lot of rope work going down into canyons all over Utah. And, it's great if everything works out, but we're really off the grid out there. And if I injure myself, I become a liability to my group. So unfortunately, I've given up some of those more extreme things. Mountain biking, I can't really do anymore. So just, running, swimming, getting on my bike, working out, just keeping my brain functioning outside of the operating room. And I cook is probably my biggest hobby now. Is I cook. I feed an army. 4 kids, 3 in college. Their friends are always over. On any Friday night, there may be 12 people at the house. We fire up the smoker and go get it. So
look at that. We got a Bobby Flay over here now, too.
Yeah, right.
That's incredible. All right, guys. We're going to get into the meat and potatoes of today's presentation, which is technologies, techniques, and tips. And we're going to start off with limb lengthening technology, and we're going to start off with bone lengthening, which is what we're all here for, limb lengthening. So I want to ask Dr. Robbins the first subtopic, which is an external fixator versus an internal nail. And do you think that one is more purposeful for deformities and another purely for limb lengthening?
So you kind of have to go back, and this is not really, because these have been discussed with you on your channel, so I'll refer people to some of your previous ones. And there's good lectures, especially by Dr. Paley, on the history of limb lengthening and limb reconstruction. But in a nutshell, an external fixator was kind of designed because you have the ability to correct multiple deformities at one time. So if you want to add length to something, if you want to add angulation to something, if you want to add rotation to something, you can do all of those simultaneously with a fixator. Well, as we get better as surgeons and we expand our own horizons and try new things, which is pretty much what we do every day at Paley Institute, we realized, well, what if I can take a crooked bone and make it straight first in the surgery? And maybe I can even correct some of that rotation all at once in the surgery. So now my crooked rotated bone is straight and rotated properly, and now it's just a short leg. Oh, well, now I can put a nail in and get the length, because the nails can go plus or minus, at least today's technology. So we're now pushing envelopes on what used to be pretty much only the realm of fixator. We're now trying to get to internal, which then kind of goes back to your question. Well, if external works so good, why don't we just use external for everybody? And the answer is just because lifestyle with the fixator is a little different than lifestyle internal, because by definition, a fixator is external to your body. It's attached to your body through pins and wires that go through skin and muscles. And there's risks for infection. There's risks for those things breaking. They're on for a long time. They get in the way with clothes. What do you do in cold weather? How do you drive a car? How do you sleep? How do you ride on an airplane? So if you have your choice and you have the same outcome of this external contraption or an internal device, then it's sort of a standard to use the internal device if you can. And sometimes, though, that you can't. Bad bone, broken metal in the bone, previous infection, the list goes on and on. So what's nice about us and what we do is we are equally facile with both. And sometimes we combine them. Sometimes we use a fixator and a nail, or fixator and then a nail, or fixator with it. The permutations are endless. But I think if you are in the game of limb lengthening, and I don't just mean stature lengthening, but if you are a limb deformity or limb corrective surgeon or trauma surgeon, you really need to be facile with both. And that's what we offer our patients. Again, whether this is for post-traumatic, post-infectious, post-tumor, congenital problems, or limb lengthening. If I can take a child with a crooked leg and make it straight and to length, I can certainly take an adult with normal intact bones and add length to them.
Right. It's much simpler with that. That's very clear. Now, Dr. Robbins, a lot of patients, prospective patients, they asked about the difference between a magnetic or an electromotive nail versus a mechanical nail.
Yep.
Can you explain the difference between the two and when, what you would prefer to use?
Yeah. So to be clear, in the United States, at least to my knowledge, the only FDA-approved device is the PRECICE and the PRECICE brand of technologies, which is magnetic driven. There is another device that has an actuator. It comes from Germany. I know there are some centers using it, but I don't know if that's FDA approved. So I don't want to speak or say something improperly. So I only talk about what I know. So I know the NuVasive product line that's called PRECICE, and the PRECICE Max that's going to be coming out. We'll talk about that in a little bit. And that is a magnetically driven device. That device in one iteration or another has been around since 2010 or 11. Dror and I have put in 4,000 nails in the last 10 years. The rest of our partners, we've put in a lot of nails. And so that is a tried and true technology. And some great things about it, it is patient controlled. But we set the parameters. So how fast does the bone distract? How much distraction in a day? How many times per day we do that? And a great thing is not only can we add length, but we can also go in reverse. So if you try to add length to somebody, obviously we're going in a positive direction, but there are some times where we want to actually reverse and compress if there's a gap, or we're treating a non-union or some other reason. So we use a magnetic driven nail. That's the PRECICE line of things. And it's an external device that has a magnet in it. It couples magnetically, you can't see it or feel it, to the internal magnet in the device. And it is a relatively easy thing to use. It's a few times today, and our patients can speak to it. It is essentially painless. We're talking about lengthening in standard scale, 1/100th of an inch per session of about 60 seconds, or 1/4 of a millimeter, which is not much, but you do that 4 times a day or 2 times a day for 2 months, and oh my gosh, you've turned an acorn into an oak tree. So that's what we use, is that magnetically driven nail. That's the NuVasive PRECICE line of things.
Gotcha. Now, you kind of mentioned it. There's been the talk of their new line, the PRECICE Max, coming out. It's a weight-bearing nail versus their tried and true nail, the PRECICE 2.2, which is on the market right now. Now, a lot of patients kind of are like, should I wait for the Max, or the weight-bearing nail, or the non-weight-bearing nail? Can you compare and contrast the difference between a weight-bearing nail, non-weight-bearing nail, and like the differences in recovery and rehabilitation?
I can't. So we did have a weight-bearing nail for a short period of time. Again, we're not pointing fingers. I don't want to name things because that's not what we're talking about. But we did have a weight-bearing nail for a while. Unfortunately, that was pulled off the market. But it also happened during COVID. So follow-up was cut short. Our patient volume was cut short. And the nature of our practice, our patients are with us for the entire distraction phase, which we'll get into why our results are so good, because our patients stay with us for the lengthening phase, for intensive rehab and close follow-up. But then they return home to finish their rehab, and I don't see them again in person usually for at least a year and a half till they're having the rods out and they've already recovered. So I can tell you anecdotally, maybe the full weight bearing patients recovered a little bit faster, but the reality is by the time 6 months, a year goes by, whether it was a weight bearing nail or a partial weight bearing nail, you're still going to recover. Your results are going to be the same. You're going to get the same amount of length. So it is more convenient for sure, because imagine if you weigh 140 pounds, let's say 70 something kilos, and you want to take a shower, but your rods can only hold 22 kilos or 50 pounds per leg. Well, do some math. You got to hold about 30 to 50 pounds, 20 to 30 kilos on your arms. Well, how do you take a shower if you got to hold part of your body weight? How do you cook for yourself? How do you get a glass of water? How do you go brush your teeth? And so our patients can speak to it. You rapidly learn how to adapt to it, and it's just part of the grind, and it's part of what you sign up for. It's hard work to get this length, and that's part of your work. So certainly, if you have the ability to stand and you are allowed to walk, then the inference and the expectation is that the recovery should be a little faster, because you're already using those walking muscles from the time of surgery. Now, a point to be made is, just because you can walk doesn't mean you will, because you may just be a little sore, a little uncomfortable, or a little bit hesitant or nervous, or your balance is off. So even with the weight-bearing nail, our patients were for at least a few weeks using some form of walking aid. It may have just been a cane or a single crutch. They may have used a walker just because what if they trip and fall? They know they're much more stable and safe surrounding themselves by some sort of cage, but they have the ability to walk. They can stand. And that's really, that's a boon. So I don't know, it's not really an announcement, but I have some proposed timeline for the Max. Do you want me to talk about this now, or do you want to save it for the segment?
I mean, I know there's going to be a segment later, but you can go ahead and fill us in now.
So we don't have firm date. We know it will be Q1 24. Q is a quarter, so January, February, March. That's the narrowed window is now January, February, March of 2024. And when I was discussing this with Dror, he said, not to be punny, but when we have a precise date, we will tell you when the PRECICE Max will come out. It will be the shot heard around the world. You'll probably be the second person to know it, Victor. Then everybody will know it. Right. So a thing to think about is, let's say it really make up January 19th. I'm just making up a date. It'll be March 20th. And you're really in your life where, boy, my life would be so much better logistically if I could do this now, then do it now. Because by the time March rolls around, you'll already be in recovery and getting over it. That's easier said than done, because I'm not the person who's going to be on the other end of it. But the reality is, we have implanted thousands of PRECICE 2.2, and you will get the same result. So I can't make the decision for you, but that's my 2 cents on it.
Yeah, I was just talking to a patient today who was kind of, confused which path to go. Should I wait for the PRECICE Max with, Paley, or should I, just go for the PRECICE 2.2? And I said, hey, man, I can't tell you what to do, but I was like, look, we don't know for sure when this thing will come out. It's like, yes, Q1, but if you get it done now or sooner, you could be done by then. Right. But
what if it's March 28th, the end of and what if it changes, right? Until it's actually in my hand and I can look at it and implant it inside of you, it's nice to have expectations, right? We're all trained for this. You hope for the best and you plan for the worst. So I will keep using 2.2 whether we have the max or not, because some patients it will just fit, or it's the appropriate nail, or it's not for stature lengthening, or whatever the reasons are. So max is another tool in my toolbox, but I can get the job done with what I have. There's no need to wait, if that's another way to say this.
That's awesome. Yeah, no, and we're going to definitely be talking about that throughout the night for those who join later. But next up, Dr. Robbins, I actually want to talk about delayed union. It's a concern for some patients. What role does bone stimulators play in promoting bone health or healing in such cases? And can you explain the difference between like lipus or low pulse and and also PEMF?
Yeah. So I'm going to turn your question on its head and say, why would you get to the point where you need to use a bone stimulator? This is a slow process, and lengthening occurs in small increments every day. There should be no surprise after a few weeks how this individual person's bone is healing. And again, I can only speak to the Paley Institute and how we do it, and our patients can confirm. But I personally will see you every 2 weeks, and I will get x-rays on you every 2 weeks or sooner if needed, and I will review them, and I will look at your lengthening. Have you lengthened as much as you were supposed to? Your expected lengthening based on what the machine is telling you and what you think you've done. Are you lengthening symmetrically? Do both sides equal each other? And how is your bone quality? And we will quite literally look at the front and side views of your entire bone and talk about your bone healing, the person sitting in front of me at that time. And I'll tell you, based on what I see, X, Y, Z, you look great, continue your current rate. Or you know what? Your bone isn't as nice as I want it to be. And if we keep adding length, it's going to take you longer to heal. We may slow you down. Bone stimulator in stature world, as opposed to in post-traumatic congenital, like what you had, different game. So in stature world, in our institute, we have access to bone stimulators. This is not through insurance. This is cash price. And if patients desire them, they can purchase it. We get nothing out of this. This is between you and the manufacturer. And you're welcome to use them. But a lot of people don't, because most patients don't need them. And nobody has yet said, let me do an experiment. I'll only use it on my left side, but not my right. Right. So, and then the other way of sort of answering your question with a different question, a different thought is, how often are we, Paley Institute, needing to surgically intervene to get a bone to heal? And in 9 years that I've been doing this with Dror, I'm sure it's happened, and I'm not thinking of the person, but that's how rare it is. And the thousands, not all in the stature, but in the cases you do, because we see you in person every 2 weeks, and I look at your x-rays, and if you're having a problem, we recognize it early and we make adjustments for you and your safety and your health. So hopefully you never get to the point where you need to use these things. So to make it simple, I have no objection using them. I've never had a patient heal so fast they prematurely consolidate using one. So that's good. So if you have one or access to one, great. What's the difference between Exogen, which you have pictured, or the other ones? We use Exogen because the nail's in the way. I don't want to get into too much of the science of it. There's certainly no harm. There's potential benefit. But again, the way we do it, they're not needed routinely at all, because we want you to make the best bone you can, and we're not going to let you lengthen until your bone is unhealthy.
Yeah, I guess that just comes with experience. A lot of people, I've heard that they have to use these. It just might be the surgeon just doesn't know, they're not experienced enough to know when not to use them. So very cool. And then the third, technology that I want to talk about is muscle recovery. Now I've come across this company called Cypher Skin in the last year, and it's kind of a biometric sensor sleeve that is slipped onto either the leg, the arm, or some sort of joint. And it kind of senses like how much flexibility, range of motion that joint has and how it progressively improves or doesn't improve over time. And I wanted to kind of see if this is something that perhaps the Paley Institute and the Rehab Center might be looking into to possibly kind of, assist with the rehabilitation after limb lengthening.
Sure. Well, I kind of feel like you just hit me with a little curveball, because I haven't heard about this and I didn't know this. So my brain is spinning as I'm reading this, going, what is he asking? So it's interesting when you start saying it's measuring and giving feedback. I'm instantly thinking, wow, what a fantastic thing, because you're getting true quantitative analysis on whatever these various metrics are. So why not? Hey, if you work for this company, send me information. I'm happy to read and let's talk, because we're always trying to get better. So why are we so good? Because of the protocols we have, because we're a purpose-built institution, whether it's for pediatric limb reconstruction or post-traumatic or stature lengthening, you know, whatever it is, we're purpose built for all of these things, infrastructure from admins to schedulers to clinic follow-up to x-ray protocols. We have it all. So if our therapists are so good because they see you every day and they're the front line evaluating you, well, if they can measure how you were on Monday and how you are on Friday, not just with their eye and not just with a ruler, but maybe there's even a better way to get information, then why not? We've sort of made our career pushing things and moving forward with technology and thought. So why not? So
That's awesome.
Yeah,
Very cool.
I'm happy to learn about it. But because I got to give ourselves a little props, we're doing pretty good without it. that doesn't mean we certainly can't do better.
Yeah, absolutely.
We're also looking for ways to improve and make the patient experience better. And then from another point of view is it actually, as I'm thinking more about it, it's actually even more engaging from the patient point of view because, right, so I'm the therapist and I'm measuring and you're 42 degrees. And then I measure on a Friday and you're 44 degrees. Yeah. And you know, whether that's better or worse, who knows? But I'm excited as the therapist because I'm seeing improvement. But if you're the patient and you're watching with your eyes as this thing is moving and you're seeing the green and the red lights do their thing, that's sort of engaging you too. So why not? It's sort of like, you know, biofeedback. Maybe you have something on at home and you're able to gauge. So I'm really very interested in this.
Awesome, man. I just gave them a big, prop right there.
Here's
Hopefully they can. Yeah, I know, right? I have to investigate it. Cypher scan, you owe me money. No, I'm kidding. Awesome. Very cool. All right, guys. So now we talked about the technology. Now I want to get into techniques and tips and actually, surgical approaches. So Dr. Robbins, we have a list of different, topics that I want to kind of bust through here. So we're gonna go through. Number one is IT band release to help avoid abduction, or people call it wide legs. This has been done in most centers, but there are a few who don't do this for stature lengthening. Can you explain why it's important for let's say, femur lengthening?
Yeah. So again, to quote Drawer, and Drawer, if I'm misquoting you, I apologize. But in the congenital pediatric realms, right? That's not, we're talking about a 4-year-old kid born with a problem where their leg is inherently short from birth, and we're wanting to add length to that leg. There's a band of tissue in that leg that's in all of our legs as normal formed adults without congenital problems. And that band is called the IT band. And Drawer will say in the congenital realm, the IT band, the iliotibial band, it is a big detriment to lengthening. It's an inhibitor of lengthening. It is a very tight structure, and it's so strong, it's very hard to lengthen against it. So in pediatric realm, we actually use that to reconstruct the ligaments and do things, but we will sometimes remove it entirely if we have lots of lengthening to do, because we know it can be such an inhibitor for lengthening. It's just very strong. So kind of as an example, so I have a piece of paper and I can rip it very easily, but if I could get a clamp on and pull this way, it has tremendous tensile strength. So the IT band is very thin, but it is incredibly strong because of the tissue it's made of. So in our institution, if you are having a femur lengthening, we will, as part of your surgery, do an IT band release at the knee. So on the outside of the knee is where this is. It's about a 4 centimeter, 3.5 centimeter, inch and a quarter incision. Not only do we completely release the IT band, but we also take advantage, and part of your hamstring muscles are there, will actually loosen the layer of connective tissue around the hamstring. It doesn't affect strength, doesn't weaken the muscle at all, but it's one more thing we can do to help you get your lengthening. It helps with the hamstring tightness, and cutting the iliotibial band at the knee helps allow the lengthening. So that band, that iliotibial band, attaches on the side of your knee below the knee, and it goes all the way up to your hip. Very rarely during our preoperative assessment, we find that not only is your iliotibial band so tight we're going to release it at the knee, we're also going to do a second release up on the side of the hip. And we probably do that, 5 to 10% is really a pretty low number. Patients then ask, but if it keeps me from getting duck ass, or if it keeps me from getting abduction, why don't we do it on everybody? Because even though we may kind of be lighthearted about some of these conversations and we talk about it, it's simple to just lengthen a bone. Let's be very clear. This is a dangerous game we're involved in. And making somebody taller who is an intact, fully functioning human being with no orthopedic issues is not to be taken lightly. And we'll get into a little bit about the psychosocial aspects about this, I'm sure. But let's be clear. Surgery is surgery, and there are risks for everything. And why do unnecessary surgery? So the IT band we found is necessary for femur lengthening at the knee, and everybody gets that. But we're not going to just willy-nilly go do the release up at the hip just because it may make your lengthening better, because that's a more involved thing. There's potentials for problems. So we don't do things you don't need. Okay. We do things you do need. But how do I know if you're getting tight? Because you're in Florida with us. You're seeing our therapist 5 days a week. And if you're having a problem, we'll get you in our clinic to see us immediately for an evaluation. So we don't let problems go out of control. Things happen slowly. And if you're vigilant and looking for them, and you have the right infrastructure and people communicating with the same language, we recognize and jump on problems fast. It is far better to prevent a problem than to treat one. Mm-hmm. But if problems exist, you have to know how to get out of a jam. And fortunately, we have the experience for treating problems, most of which I'm happy to say are coming from other institutions. But yeah, so roundabout way of saying everybody gets an iliotibial band release at the knee. That's very important to help with your lengthening.
Okay, very cool.
Femurs.
No, for femurs, yeah, absolutely. No, definitely, that makes sense. Now, the next thing, I get this question all the time, and it's about which size nail am I going to need for my lengthening, and what weight-bearing capacity will I have for that? So how does a surgeon kind of measure the diameter of the canal of the bone to kind of determine what nail size they need?
So measuring the diameter of a bone on the outside part of the bone doesn't help us much, because the rod goes in the narrow, hollow part of the bone. So if you take a chicken bone, you get a chicken wing and you break it in half, and look, it's a hollow tube that has a certain width of, I don't know, 0.5 centimeter, 5 or 6 millimeters. And then there's a relatively hollow part, and that's the soft, mushy bone where the bone marrow lives and the fat inside the bone lives. So a bone is wider at the top, and it's narrow in the middle, and then it's wider down at the bottom. And the femur has a longer, skinny part than the tibia. The tibia is wider at the top. So we only need to remove the bone where it's the tightest in the middle. Some patients, we can look very clearly on the x-ray, and I can measure the vast majority of your canal is this. I'll make up a number, 12 millimeters. And then there's just a very short segment where it's 10 millimeters. And then for the rest, it's 12 or more. Well, I only have to remove a small amount of bone along that length, so that's less bone being removed. But some patients have a very narrow canal along a very long length. And that means we have to remove a small amount of bone to get the rod in over a long length. So removing more bone. Well, eventually the rod's going to come out. Is there enough bone left for them to have a sound, intact bone to run, jump, play, and do other things? So sometimes it's easy to know before surgery, you're going to have no problem with the biggest diameter nail we have. Sometimes it's, boy, it's going to be tight getting the smallest nail in. And that's kind of, sometimes we have an idea before surgery, but we always have the ability to make the intraoperative decision. So the surgery from a technical point of view, all orthopedic surgeons are trained to put a rod in a broken bone. You can certainly put a rod in an intact bone. But we have tips and tricks and things we do to try to minimize problems such as the fat embolism. We do things to help stimulate bone healing. But this isn't robotic where 42 kilogram patient, 10 millimeter wide bone gets nail A. You have to think too. And you have to get feedback during surgery and make decisions as you go. So this isn't monkey robot surgery. These are serious surgical techniques, and we have the wisdom and experience to make intraoperative decisions based on your bone, the person I'm operating on right now. What I did for the other person next door is wonderful and great, but now I'm focused on you, and I'm going to adapt the rod you get to the safest one that will fit inside you.
Wow, it's kind of like flipping a coin and say, I pray I get the biggest nail, but not always the case.
Okay, so let's talk about nail size again. So a bone, whatever the bone is, just the way nature and things are and the gravitational field we develop in, a bone has a length and a width, and a longer bone has a bigger width. By extension, our patients who are coming for stature lengthening are shorter than average typically, which means a shorter bone will be narrower. The flip side to that is if I'm operating on a patient who broke their leg on a motorcycle accident and they're 6'2", their bone will be longer, which means by definition it's wider. So I know they would take a larger nail. Well, if you were 6'2" or whatever the height is, 185 centimeters, you probably wouldn't be having this. But the point is, if you're 4'9", you have a shorter bone, which means a narrower bone, and that's where we do our best guesstimate before surgery what rod we're going to use, but we really make the decision in the operating room based on how your bone is responding to what we're doing to it.
Gotcha. No, that makes sense. Have there been patients who have been below average height that gotten the biggest?
Yeah, actually there have, and there are some. Yeah, I don't want to use the wrong terms, and I'm really trying not to offend anybody. There are databases of bone studies based on, geologic areas.
Wow.
Whether it's Asia, it's Indonesia, it's wherever. So there are certain there's patients with certain gene pools who may have narrower water bones. But nowadays with worldwide travel, and just because you were born in Mongolia or you're born in Kansas City doesn't mean your people for 1,000 years didn't come from, the steppes of Middle Europe. So, taller people generally have wider bones is a safe thing to say, but there are regional differences. But again, that's why we get x-rays before surgery. And we have an in-person visit before your surgery so we can look at your x-rays and talk about what we're going to do for you, which I think is critical to have that in-person visit before we do surgery on you.
Yeah, and not to delay too long here, but I know you guys also have the EOS x-ray machine. What's the difference between that and like just a typical long-standing x-ray?
So nice thing about EOS is it's less radiation.
Okay.
And you stand in one place and it takes a front and side view, as opposed to traditional x-rays. You stand in one position, then you turn position. But it's really, it's pretty quick. It's less radiation. And you can get good measurements for angles. And as the software is applied to it, you can actually get 3-dimensional analysis of bone shapes as well. So it's pretty slick. That's a pretty cool recent addition to us. We always had an EOS machine in our hospital base, but we now have one on site. So we're actually looking at how we can do research on this to assess alignment and all sorts of things. So EOS, basically it's faster and less radiation, and you can see the whole body head down as opposed to just the legs or just the spine.
Wow. So you can check out any potential deformities along the way too.
Yeah,
really
exactly.
Very cool. Awesome. So, Dr. Robbins, we're talking about primarily stature lengthening tonight, but a lot of patients, they always wonder about proportions and measuring their bone lengths and seeing the tibia to the femur and all that stuff. So where do you really, I know we don't have a picture of a tibia and a femur here, but like, where is the right place to measure, or is it properly just to use an x-ray and go from there?
Let me just say this. You can measure it however you want. Your ratios are normal. Just that's unless you have a known orthopedic condition or known genetic condition, or you know it visually. Not almost. A large proportion of our patients say, "I know my legs are out," and they're really not. The variation is the length of your tibia is about 80% of the length of your femur. Your tibia plus foot is about the same length as your femur. So if you bend your knee, your hip, the bottom of your hip is about where your foot is on the floor. Lever arms and mechanics and things like that. So everybody's ratio is 78 to 82% plus or minus. We're talking millimeters. Another way of saying this is the amount of length most people are wishing to add, 3, 4, 7, 8 centimeters. By definition, number A over number B, your ratio will fall out of the normal range.
Yeah.
The ratio doesn't mean anything because it's an aesthetic thing. So I'm not going to tell you, Victor, you should have 6.4 centimeters length. I'm going to tell you first, you're going to start at 1 millimeter, and we're going to assess how you're doing. And I'll worry about your 7th centimeter and how your bones look after you get to 6.5. So you will have ample opportunity to look at yourself in a mirror every day and measure your height on the wall and measure your legs, however you choose to analyze yourself, and say, my legs are 4 centimeters longer, and I'm now 1.5 inches taller. And when I look down sitting in a chair, my knees are extended that much more. It's not that often, but a patient will come in and say, I'm 4.5 centimeters and my legs are starting to look a little bit long. I'm going to stop. Great, wonderful.
Wow.
You are by no means obligated to go for 8 centimeters because before surgery a year and a half ago, you thought that's what you wanted. If the nail went to 9, people would want 9. If it went to 7, they'd want 7. So you don't know what you don't know until you're going through it. But a pretty good number, 20, 30%, I would say, if their goal is pretty set, will actually change it for various reasons. Their bone is slow, their muscles are tight, they're not participating in therapy, they just want to go home, there's a family emergency, whatever the reasons are. Well over 90% of our patients will reach the goal they want, but a good percentage moves their own goalpost. We are so on top of you. If you're getting into trouble, we have things to do to help keep you on track because that's what you're seeing us for. You can go somewhere else and do whatever your thing is. But if you work hard and we follow you closely, we're going to help you get your goal. And pretty darn much everybody's going to get their goal, which is a pretty cool thing.
That's definitely a very cool thing. I had that question asked, like how many patients hit their goal, and I think it's at the really good experience clinics, so like you guys, it's over 90%, over 95% or higher.
So Jor and I wrote the paper on this with the weight bearing nail, and it came out, I don't know, a couple years ago. And again, without getting too much into statistical analysis and a limb lengthening article, how do you define success? Is it the goal they thought before they had surgery? Is it 5 millimeters is okay to be off of the goal, or 10 millimeters? Like, where do you define a normal range? And it was actually hard to come up with it. So we define success as lengthening within 1 centimeter of your goal.
Okay.
It could have been 8 millimeters. It could have been 4 millimeters. At some point we had to prove a cutoff. Why a centimeter? Because there's a huge number of people running around right now with a centimeter or more leg length difference, and they don't even know it.
Right.
So anyway, I'm belaboring the point, but you can lengthen up to 8 centimeters safely in the femur, 5 centimeters potentially in the tibia. We will never guarantee length, but we will guarantee we will do everything in our power to keep you safe and prevent you from getting into a place that you cannot recover from. Because what's the point of being taller if you're not back to your normal function? So we won't ever sacrifice function for length, or let you sacrifice function or length, because my job is to keep you safe, because you don't know what you don't know. That's why you come to us.
Absolutely. Experience matters. Actually, continuing on with proportions here for number 4, it's actually about talking about, I get this also a lot, it's about skewed limb length proportions on joint health. So let's say that a patient just comes in, they do achieve the 8 centimeters in length on their femurs, and they get back to the gym and start squatting. Is this biomechanical skewedness going to affect their knee or hip joint?
Yeah, so it's a great question. We don't have an answer. As Jor will say, because I heard him say it yesterday, I've been doing this for 37 years, and I haven't had a patient come back with a problem from it. Now, we're not doing, biometric testing on somebody 37 years later, but in 37 years, I'm going to have hip and knee problems, and I haven't had lengthening surgery. So again, you asked me a very straightforward question, and I'm giving you my politicized answer. But when I got into this part of stature lengthening with Jor, really, so I've been with him for 9 years, but probably about 7 or 6 years ago, as the numbers started increasing, I started doing this with him regularly, as we do it now. And we had a patient who was 55 years old, which 10 years ago I was not 55. And we were talking about his functional return, because he had done lengthening, I think 7 or 8 centimeters in his femurs. And he was an avid runner, like a weekend warrior type. And he knew his 5K time, make up a number, 28 minutes, whatever it was. And a year and a half later, he comes for his removal. Hey, how's your 5K time? And he said, I'm 2 to 3 minutes slower. And he said, but I'm also 2 years older, and I will always be taller, and I will not always be a runner. So I would gladly sacrifice 10% of performance ability to always be taller, because I'm not here for stature lengthening because I don't run as fast as somebody. I'm here for stature lengthening because the way I perceive myself is related to my height being shorter. It's not to my athletic prowess. Right. So again, I'm answering your question with all kinds of words and talking around it. But we don't have proof, or people aren't reporting to us, but it's still relatively short term. The vast majority of stature lengthening has been done with internal nails, and probably more were done in the last 5 years than in the last 40 years combined. Without diving into the numbers, that's probably a pretty accurate statement. And so we'll really know in a few decades. So we can ask our patients when we get them online, but these are some of the things we talk about. We don't know the long term. And would you be willing to sacrifice potential, a little bit of arthritis or some problem 30 years down the road to affect your height? And that's a pretty fair question, because that's quite literally what you're asking. Yeah. If you go get a nose job, or you have a breast augmentation, or you have a facelift, or you have liposuction, the chance of you being crippled and in a wheelchair is probably close to zero. And those are called cosmetic surgeries.
Yeah.
Stature lengthening or limb lengthening surgery, cosmetic limb lengthening surgery, is in the realm of a cosmetic augmenting procedure. And you have the potential, God hope it never happens, God willing, that you could become crippled for whatever reason, or in a wheelchair for a short period of time or forever. You walk into my clinic, the expectation is you walk out. But somebody somewhere is having a bad outcome, whether it's the fault of the surgeon or just one of those things that happens in life. But if it happens to you, it's 100%. Yeah. So this is not, and now we're getting back into this. This is not to be taken lightly. This isn't something you do because you have time and money and you got 3 months off between jobs. Yeah. This is a really big thing. This isn't cosmetic surgery like your boyfriend or your girlfriend or your mom or your dad had when they were 50 to get their appearance. We are breaking bones in your body and asking them to stretch with the nerves and the blood vessels and the tissues and the skin and the muscles, and then getting you back to where you were before. So it's in the realm of cosmetic surgery, but this is not cosmetic surgery that most people think of, like tummy tuck, liposuction, facelift. They may be in the same name, but this is a very, very serious thing. And you really have to understand the potential risks. We may make it look easy, or we may make it look simple, and the techniques are not that technically challenging, but it's because we do it a lot. And we know the things to try to prevent and look for. So cautionary tale, you really have to understand what you're getting yourself into, because if something bad happens, and statistically speaking, it's going to somebody, and that's going to be a person who's a mother, a father, a husband, a wife, that can be devastating. So you really have to understand 99% of the time, everything's great. 99.5% of the time, everything's great. But if it's not, there are consequences to this, and we don't take it lightly at all. Right. When you wake up and I talk to you and examine you the night after surgery, and we're talking and everything's good, that's when I relax for the day. And then when I come in the morning and I know you're still good and I'm not getting phone calls about concerns, I rest much better, because this is serious business.
Yeah, absolutely. I mean, that safety first, that's what matters so much. And it kind of brings up our next topic, and it's talking about inexperienced clinics, because just recently in one of my consultations, I've actually a few of my consultations, I've heard about this, and that's point number 5 here, doing quadrilateral limb lengthening on the same day, with primarily lengthening over the nail at some clinics that still use it as an obsolete method, as I think. I want to kind of get your thoughts on how risky this is, because we know that, obviously there is something called fat embolism, which is a very risky complication that can happen with reaming of the bones. So can you talk about clinics that are doing this and the risk that patients face by going to these clinics that are doing this?
Yeah, so I have no experience with doing quadrilateral lengthening on the same day with reaming bones for stature lengthening. So Dror tells a story. He had a patient, and I think MD, physician by training, maybe even anesthesiologist, like somebody who knows about these things. And he and Dror had the discussion, and I think as part of his case, they did medical imaging where they actually had a transducer down in the throat looking at the heart. And as they were reaming the bone, they were seeing how much fat there is, and they're doing all the anesthesia things. And this person successfully underwent quadrilateral, but there was fat being showered into the lungs. So there is some critical amount of fat from the reaming of the bones, from the bone marrow, that goes to the lungs that your body just has a hard time processing. So in our practice, if we're doing quadrilateral, we do tibia first. We give you a 2 to 3 week your body chance to recover, and then we do the femur lengthening. So why do we do tibia first? Because you have to bend the knee all the way to be able to get the rod in, and you lengthen slower, so it takes longer to get your length. So if you do tibias first and then you do your femurs, by the time your tibias are done, your femurs have caught up, usually for about a 10 centimeter lengthening combined, if that's your goal or you can get that far. So I have no experience with quadrilateral. If it works and they're doing it, it would be wonderful if they publish their work. If 5 patients a year have it, maybe it's a statistical anomaly that no one had a fat embolism. But if one person does, if the 6th out of 5 does, that's a 17% incidence. That's pretty darn high. So if people are doing it and have good numbers, please share the knowledge, because maybe we need to reevaluate, but doesn't seem safe to me, doesn't feel safe to me. Separating tibias and then femurs, it's nice to give your body a bit of a chance to recover. Just one surgery is hard enough to recover from. Imagine having above and below the knee, doing the therapy. Maybe what does that save you, 2 or 3 weeks in time? I'd rather have one, recover from that pretty nicely, and then have the other. Whether it's safer from a fat embolism point or not, it's a lot of surgery to do on one day for no reason. Anyway, so that's my feeling. I'm a believer in 2 bones reamed at a time.
That's fair. That's definitely fair. Very cool. Keep it bilateral, guys, on the same day. All right. Next point is actually, and this is kind of my feeling on this, like using LON for cosmetic limb lengthening or stature lengthening. And, some clinics still do the monolateral lengthening of the nail. I just feel like I've seen a lot of axial deviations, knocking varus and whatnot from this technique for, let's say, the tibia. What are your thoughts on this for stature lengthening as we go forward into the future with, this procedure as it grows? I mean, it's becoming more popular. We know that, but what are your thoughts on that, Dr. Robbins?
Well, so the first question is, why are they doing that? And the obvious answer is because they don't have access to the PRECICE nail. Either it's cost prohibitive, it's not approved in their country, or they're just choosing not to. So obviously, if you have the ability to do this all internal, we would want to do this all internal, less infection, less problems. So again, we don't do it, so I can't speak to the experience of other people. Dr. Paley, I think, first published on lengthening over nail in like 1991. So he knows a thing or two about it. And in the scope of practice and technological development, PS, who happens to be the lead surgeon designer of the Max, Troy Paley, lengthening over nail was great in the 90s, but here we are in 2023. But we have access to internal lengthening nail, whether it's PRECICE, NuVasive, or in another country, they have options for other things. So any technology, just because it's new doesn't mean it's better. Let's be very clear. If you are skilled and understand the principles, there's no reason why lengthening over nail can't have wonderful results as expected, with a little more discomfort from the fixator. But once the fixator comes off, you should be able to correct for axial deviations or whatever other problems are happening. Just because something's newer doesn't necessarily mean it's better. Okay. I give a talk on, and I forget how I worded it, kind of some witty way of wording it, is something that we do, and Paley Institute, we do is look at existing technologies and techniques and say, how can I use that thing, but do something else with it that nobody else has done? And so you don't need a new widget. There's plenty of widgets out there. Maybe you need to have a new way to use an old widget. So, and maybe that's what lengthening over nail is. But to kind of be clear, you have to know what you're doing to get into this. And so just because you can put a fixator on and you can put a nail in doesn't mean you're going to be a skilled lengthening over nail fixator surgeon. And these are fair questions to ask your surgeon. This isn't a paid promotional advertisement to come have stature lengthening at the Paley Institute. This is me and Victor talking about something we're passionate about. If you happen to come to us, great. But this is you hearing from me as an experienced surgeon, the things that go through my mind that you as a patient should consider and ask. If you come to me, that's great and wonderful. I hope you do. If you're going to go to somebody else, ask them these questions. Why are we doing lengthening over nail? How are you going to prevent these problems? Can you show me the examples? What if you get into a problem? Have you had it before? How are you going to get out of it? Questions to ask me. So you'll ask your surgeon whether it's limb lengthening or rhinoplasty or getting your cavity filled. I empower you to be your own advocate and ask these questions to whoever's taking care of you for anything.
Yeah, guys, take notes right there. I mean, that's a lot of you guys are asking me, how can you find a good surgeon or a very experienced surgeon? Use those, I guess, screener questions when you're consulting with them to find out if they are experienced enough to take care of you. So, Dr. Robbins, the next question I have is kind of a brief question. It's talking about flying after surgery. So some clinics, they'll let you go home, soon after surgery. But how soon is too soon when you just had your legs broken for stature lengthening?
So for our patients, the answer is you can fly home after you lengthen, which is at least 2 to 3 months, because our patients are getting 3, 4, 8 centimeters, depending on their circumstance and body part. So would I have big giant surgery and get on a plane 10 days later with my legs broken? Probably not. First of all, how do I know I'm not going to go to my country of origin? And if I have a problem, who's going to manage me? Who am I going to go talk to? We had a non-stature patient who had limb corrective surgery a couple of weeks ago and drove home a couple of hours and was having a problem. And he's calling me, and I'm trying to talk him through. And I said, come back and see me. I can't come see you till tomorrow. So he goes to the emergency room, and they don't know what he had. So I'm talking on the phone to the emergency room provider, very knowledgeable person, but just not knowledgeable about this. And he got in the car and came and saw me today. So our patients are obligated to stay with us. We don't have the problem of them flying home too soon after surgery, because they're weeks to months after surgery. That's surgery to break the bone and put the rods in. When you have removal surgery, most of our patients, if it's a car drive local, they're driving home the same day. Okay. But if it's a couple hour flight, maybe they're leaving the next day. If it's an international flight, maybe they're staying for a day or two. That's after removal. We're not breaking bones. We're not reaming bones. There's no risk of fat embolism, So if you're going to fly after surgery, what are you going to do, or who's going to manage you if you have a problem at home? How are you going to get in touch with your surgeon or someone on your care team to help you manage the problem? We just had a patient who had surgery at an outside institute. Within a few days after surgery, the osteotomy site opened up, and within a few days later, you could see the nail through the distraction gap across the room. He was in the hospital for 7 days and never saw his physician. He got on a plane, he came to us, and we're taking care of him, but goodness gracious. So if you're going to fly, what are you going to do to prevent getting a deep venous thrombosis? I personally wear compression socks every day to work when I'm standing, and I wear compression socks when I fly, and I've never had surgery. I take aspirin when I fly international. I'm 52 years old. To die of a blood clot on a routine flight would just be sort of crazy. So I worry about flying, and I haven't had surgery. So there can be too soon. How soon is it? I don't know, because our patients aren't leaving.
Yeah, right. They're staying with you the whole time. Gotcha. All right. The next question is a pretty simple question. I think you might have even mentioned it before, but this is brought up again recently. It's about rotational deformity correction and doing limb lengthening at the same time. A lot of people may have some sort of rotation. They said, hey, can I get this corrected, or should I do it first? I have heard you say that you could possibly do it simultaneously. Yeah.
So depending on where the rotational problem is, whether it's up at the hip, so your feet rotate in from the hip. So if my shoulder is my hip, if my hip rotates in, my knee rotates in, and my foot rotates in. So if you walk with your feet pointed inward and your kneecap pointed inward, then that rotation is up at your hip. If you walk with your knee pointed straight, but your foot points out, then the rotation is somewhere in your tibia. So there are extreme amounts where we don't want to do too much acute correction at once, but it is not that common that we do it. But certainly within pretty normal parameters, we can make rotational adjustments and angular adjustments. We can rotate position of the feet, but we can also correct bow legs or knock knees at the same time, depending on where the deformity is. If it's in the tibia and we're lengthening tibia, then we can correct the tibia deformity. If you're having femur lengthening, but the problem is in your tibia, we can't correct it because that's not where the problem is. So yes, it is possible to do a correction of a deformity if it's in the bone you're doing, depending on where it is. It's safe to do.
Great question. So, like, let's say that they did want to lengthen the femurs, but they had bow legs in their tibia. Should they get the correction first because you're fearing like maybe some knee stress? Yeah.
So we've had patients do it a couple ways. We've had patients where they have no idea they have a couple degrees of bowing. It never bothered them. But when we're analyzing your x-rays, I'll say, look, you're 4 degrees bowed. I'm bowed. I'm probably 4 or 5 degrees bowed, and it's never bothered me a day in my life. My dad is much more than that. Never bothered him a day in his life. So we don't fix it just because it exists. We fix it if it's problematic, either functionally or cosmetically. If you're 6 feet tall and you have a 5-degree angulation in your bones, it's the same 5 degrees if you're 5 feet tall. But why does it look worse if you're 6 feet tall? Because if I have a 5-degree angulation, if I have a 5-degree angulation between my hands, and my bones are only, gosh, I can't get my face out of the way. 5-degree inclination, my hands are here. But imagine now my legs are a foot longer.
Yeah.
That 5 degrees looks much worse.
I see.
So if the angular deformity is bothersome to you and it's in the area we're doing surgery, yes, we can certainly correct that at the same time too.
Very cool. Very cool. That's going to be
complicating your simple question.
No, not at all. I think that's going to be music to many patients' ears that have asked me about that.
Can be corrected simultaneous with lengthening safely.
That's awesome.
That's your soundbite.
That's it. We'll clip that right there.
Yeah.
All right. And then the final technique and tip that I want to kind of ask about is nail insertion for both the femur and the tibia. So we know that for the femur, there's the piriformic entry and the trochanteric entry. So what do you guys use for the surgical approach at the Paley Institute? And then if you can talk also about the starting point for the tibia.
Yeah. So 99.5% we use piriformis entry to the femur. Piriformis entry is what's existed since intramedullary nailing existed by Kuntscher in Germany in the 40s. Piriformis nailing for us as stature lengthening surgeries is easier than for most surgeons because we are operating on people with an intact bone. And in general, we are operating on people who have a relatively average BMI, body mass index. They're not obese. Most nails placed in femurs are in broken femurs in trauma patients. And speaking from experience in trauma centers in the United States, a good portion of these patients have some amount of obesity or being overweight. Not judging their body habit, is simply saying a larger leg is harder to operate on, especially if it's broken. It's easier to get a trochanteric starting point in a broken leg. It's easier to get a trochanteric starting point than a piriformis starting point in a larger patient. So our patients, by and large, are relatively thin and have intact bones. We take advantage of that, and we do piriformis entry. It is right along the long axis of the bone. In our hands, pretty straightforward to get the starting point. You're not doing as much reaming of the muscles. So we do piriformis.
Gotcha. Very cool. And then, and then for the tibia, like avoiding, so some clinics, people have complained about axial deviations because of improper insertion of the nail in the tibia. Can you talk about that?
So tibia is tough. I mean, femur lengthening and tibia lengthening are both bone lengthening, but if you had to pick one, femur is the more straightforward one for many reasons. It heals faster, it lengthens faster, it's easier to rehab. Why is it easier to rehab? Because the length of my leg below the knee is this long. That's a handlebar. That's a lever arm. That's a wrench I can use to work on getting my knee motion. Imagine I'm having lengthening of my tibia and my foot is only this long. That's my whole handlebar. That's my whole lever arm. That's my whole wrench to work on your ankle motion. If I have a big bolt that's stuck under my sink, I'm getting the longest wrench I have for lever arm and mechanical advantage. So rehab after femurs in general is easier because you have a longer lever arm to do your therapy on. So tibias are tougher because of that, but also the top of the tibia is shaped like a big giant triangle and the nail is only this big in it. And if the bone cut is very high, there's a lot of room for the nail to move. So we have techniques with the starting point, we have techniques with blocking screws, but even in the best hands, axial deviation or whatever you want to call it, angulation can occur. The nail can bend. What if the fibula bone, the small bone on the outside, heals so fast that every 3/4 of a millimeter you lengthen the tibia, it has so much bone, it only lengthens a 1/2 millimeter. Well, over a couple of weeks, that can start to cause deviation. They're not common when those things happen, but they can. So in general, if there's problems that are going to occur with deviations, they almost always occur below the knee. Fortunately, they're not that common, but if you don't have surgery on the tibia, you can't have deviation in the tibia. So more reason, femur is by and large what most patients opt for, simply because most patients are pretty sure they want more than 4 to 5 centimeters. So all things being equal, femur is the most common thing we do. Faster, easier, more likely to get a higher length. Anyway, less potential complications. It's only 2 bones instead of 4 bones. It's a little bit cheaper. That's certainly something to consider. So deviations can occur even in the best of hands. What do you do about it if they do occur? Well, you fix it. How do you fix it? It depends on what the problem is. Do you fix it before the lengthening is over? Do you fix it at the time of a follow-up. And what prompted your question was, if someone has a bowing in the tibia, but they're lengthening their femur, would we correct the bowing of the tibia before or after? So what I generally tell people, if I show you something on your x-ray that you didn't know existed, it shouldn't suddenly start to bother you now. I'm 42 years old and you showed me I have a 4-degree bowing. I know what my legs are doing. So you put a name to it. It doesn't change the way my legs are, right? So do your femur lengthening. I know you're coming back to me at some point in a year to get the rods out. If now for the last 364 days, it's been bothering you about your knees, you know what? When we take the rods out, we'll fix the angular problem. So that's kind of a way I approach it. Again, we're not going to fix a problem because it exists. We fix a problem because it bothers you functionally, psychologically, intellectually. We don't just fix it because it's there. We have to have a rationale because there are risks to everything we do. We don't take these things lightly.
Right. It's got to be symptomatic to make it make sense.
Right.
That makes sense. Okay, very cool. Well, that was an awesome discussion on the techniques and tips. Let's go ahead and move right along here. And we're going to go ahead and kick off our patient case section. That's right. This was a very popular section last year when we did it with Dr. Paley, and we're going to do it with Dr. Robbins today. So we have 2 patient cases that were submitted. The first patient case, I'm going to go ahead and read the synopsis and some of the symptoms that this patient was experiencing. And Dr. Robbins is going to do his best because he doesn't have the patient here to kind of virtually diagnose this patient. So this was a female patient, bilateral tibial lengthening in September 2023, so just about a month ago. Experienced sciatica pain in the right leg 2 days post-op. A lumbar disc protrusion at L5 to S1, previously asymptomatic, was now identified. The surgeon attributes the pain to the protrusion and epidural that was used in surgery. The pain now shifts between the legs from the lumbar region to the feet. She can't sleep well. She's averaging only about 3 to 4 hours, sleep per night. She used lots of painkillers, but now she's minimizing it. She stretches all day to keep mobility there, blood flow and whatnot. She's lengthening at about just about 0.8 millimeters per day. And she's a little taller, but she says that her patient plea to Dr. Robbins is nerve pain a concern for limb lengthening? Will it resolve itself? If so, and when? Yeah.
So obviously we're taking partial information. We don't have the patient to go into. My guess is that this patient probably had episode of pain in the back before, whether remembered or not, because it says disc protrusion that was previously asymptomatic. Well, how do you know it's previously asymptomatic? It meant you knew it was there. Why'd you know it was there? Because you had symptoms at some point in the past. We're not judging the patient. There's nobody's fault here. We're going with the information we have, and I have to kind of attack it that way. Right. So quick answer. Yes, nerve pain is a concern with limb lengthening. Most nerve pain is on the sensory nerves. Well, by definition, if you're having pain, it's on the sensory nerve. Most nerve problems are on a sensory nerve. A sensory nerve is one that feels pain, pressure, touch, electric tingling, whatever, as opposed to a nerve that does strength or motion. So your brain to your spinal cord to your nerves do different functions. The nerve that makes me feel my thumb is a different nerve than the nerve that makes me move my thumb. Mm-hmm. So just because my thumb feels funny, my thumb can move, or vice versa, whatever the permutation is. Same thing in the legs. So nerve pain or nerve irritation or feeling electricity or tingling, 15, 20% of patients will get that, but there's no weakness involved. Mm. Weakness, loss of nerve, muscle strength or function is bad, is scary. That's a hard stop. Your lengthening is done until we get this under control. We had one patient in the last 9 years who, I don't remember if it was femur or tibia, but got a little bit of weakness after, I think it was tibias, after 3 to 4 centimeters and we hard stop. Dror said that is the second time in 30 years of any lengthening, not cosmetic stature, that he got weakness associated with it. Yeah, we get a little numbness, we get a little tingling, we can talk about that. So weakness is a hard stop. Now, if you think about it, the nerves go from your brain to your spinal cord and then from your spinal cord down to the tips of your toes. Mm-hmm. Whether you're lengthening tibias or femurs or both, that nerve is being stretched below the knee or above the knee, and that stretch goes from the tip of your toe all the way to where it is in the spinal cord. If you happen to have a protruded disc from 30 years ago playing rugby, or you're just 52 years old and the space in your spine and your nerve roots is a little bit compromised, yeah, absolutely, those nerves can get irritated. So what are you going to do about it? Who's going to recognize it? Who's going to take care of it? And certainly appropriate stretching, appropriate therapy, appropriate rehab is very important. We happen to have, and we'll jump ahead to your later topic, at the Paley Institute, we have a tremendous cadre of surgical and non-surgical spine specialists, physiatrists, rehab doctors. We happen to have neurosurgeons and orthopedic spine surgeons, but we have a lot of people that can help us, and we would work you up and do non-surgical things, whether that's imaging or therapy, steroid injections, whatever it is. So if you were having this problem with us, we would get our spine and back team on top of you to figure out what the problem is. So let's take advantage of this and go to a little side section. Let's say you're my age, you're 52 years old. Every now and then you have a little bit of back pain. Your height has been bothering you. You've been thinking about this for 10 years. You've been saving money. You have time off. The kids are taken care of in school. It's now time to take care of you, and you want to do this, but you've had some problems in your back. What can you do to prepare yourself for surgery? Prehab all day long. My wife happens to be a physical therapist, so I hear all day long how physical therapy and core strengthening and all these are the best things in the world, and you have to do it. And she's listening to me. She just snuck by to go to the closet as I'm talking to you. You hear her giggling in the background. But if you know you have a back problem or you know you have problems, this surgery is elective scheduled surgery. There is no surprise you're having this. Take 3 or 4 months to get a couple of pounds off, get back in the gym. And you don't need to go to the gym to do core strengthening, but strengthen your core, get some flexibility, get your body prepared for the onslaught of what you're about to do to it. So we have like 10 different topics going. So let's go to your specific question. Is nerve pain a concern? Yes. Most of our patients who get nerve irritation or nerve problems, vast majority is a sensory nerve, tingling, numbness, whatever. We use a medication called Neurontin or gabapentin. It has a very good safety profile. We start at a very low dose. It has a super high ceiling, and the vast majority of our patients get very good, if not complete relief, on a very manageable dose. You'll take it for the whole time of lengthening. It's like a blood pressure pill. Even if you don't feel your blood pressure is high, once you're on it, you take it. Yeah. It's not like a headache pill. Oh, I have a headache, I take my medicine, and next week, tomorrow I don't. Mm-hmm. If we start you on this medication, you build up to the level that's working for you. You stay on it for the remainder of your lengthening. You stay on it for an extra week or two till your body starts to loosen up after you finish, and then you'll start to taper off. So we use it. Probably 20-25% of our patients have it. And to my knowledge, all of these numb areas or these irritated areas completely come back to normal. Nice. The way I think about it is if you've ever chipped a tooth, for the first week or two, all you can do is explore that chip in your tooth with your tongue and things, and you try to floss and it break, so you get a chip in your tooth. But after a few weeks, your brain sort of erases that problem. So whether the numb spot, your brain is just sort of forgetting it was there, or the nerve itself is repairing itself, or the outside nerves are coming to fill the defect, or it's all of the above, when they come back a year and a half later to have the nails out, it's not a concern. So, but my therapists see you 5 days a week. I see you every 10 to 14 days. We're going to know it's there early, and we're going to talk about it. It's not going to be a surprise 3 months later when you fly in for your follow-up, because that's not how we do things at the Paley Institute.
Right. You would know about it tomorrow if they had a problem today. So very cool. Her second question was, so this is about flexibility. Is it normal to only have 90 degrees of knee flexion 17 days post-op?
Yeah. So I'm presuming this patient's having femur surgery, and some people get a lot of swelling. Some people don't get much swelling, but the amount of motion you have at 17 days in our institute, surgeries today, lengthening starts 7 days later. And then, so 17 days later, they would have about 1 centimeter of lengthening in a typical femur patient. That 90 degrees, I have a feeling in the next 2 to 3 weeks, is going to be up to like 110, 120. So you're on my radar, and I'm concerned. But someone's.
But we just had one of your other patients come on. Yeah.
So it's good to know. Maybe we have this bionic skin and we get 91 degrees tomorrow. And right? It's good to know. But again, you're with us. We have good hard metrics. Where were you today? Where are you tomorrow? So we're following you. So a single point in time, 90 degrees, 17 days post-op, it doesn't make me worried. Now, if one goes to 120 and one only goes to 90 and one is very swollen and there's pain, different story. But all things being equal, at 17 days, it's worth noting, but let's follow how you're doing in the next week.
Okay, very cool. Yeah, it could just be some swelling that needs to go down. All right, moving right along here. This is patient case number 2, which I think is a little bit more severe. This patient had his surgery abroad, and he developed a case of axial deviation and malalignment. So just kind of going through the left side of the symptoms here. He had his procedure done on his tibia in late February of this year. He began lengthening in March. Tibia was naturally shorter than his other side.
Okay.
He gained 10 centimeters on his tibia, somehow
Not
without
combined?
complication. What's that?
10 on each?
10 centimeters on each.
Oh my
Yeah.
gosh.
And now he said he had no complications except for alignment issues, which that is a complication. Now he had alignment problems in both legs. He noticed this in May or June of this year. His right leg developed varus and his left leg valgus, which I found out was called a windswept deformity. Yeah. And he sent x-rays and updates. We have them. We're going to go through them in a second. His doctor that he got it done with said that he should continue lengthening and fix the alignment later. So I think that may be a red flag, but we're going to continue on here. He finished lengthening in late July. Nail hinges were installed with an external fixator. He started working on his alignment issues. By mid-August, the varus in his right leg was somewhat fixed. His left leg only 50% better. His x-rays showed that the tibial alignment was well out of alignment. And the doctor said that the valgus was within normal range, despite some of the knee pain that he had. And his doctor just basically said, try to come back a year later. And then possibly now he's suggesting that he gets an internal nail to help fix it. So he's seeking advice from the best in the world. Dr. Robbins, what do you think?
So there's a lot of ways to attack this, but first and foremost, so the axial deviation didn't happen overnight, right?
Yeah.
It was a gradual thing. And if you're having x-rays every 2 weeks, we're going to see it. So as I hope the patients will confirm, my belief is that during every clinic visit, we will review your previous x-rays, because I don't want to know just where you are today. I don't want to know where you came from. So I hope my patients can confirm, not only do I think I do it, but I actually do it, because it's important to know that's how you find subtle things. As you look at the first x-ray post-op and you look at the fourth one, oh yeah, there's something I missed. Because small things happening every 2 weeks you may not see, but if you look a month and 2 months back. So it had to have been there. Maybe it was just not noticed. So an Ilizarov device is the granddaddy of multiplanar deformity correction. Since the 1950s, this was created to fix every kind of deviation, axial, rotatory, angular. You got it on, fix it. So that's the first thing. I have no problems with the idea of saying you got your length, finish your rehab, switch to a rod, because the rod is straight. If you put screws in the right place, you put the rod in. The problem is, I don't know if these pins were placed in such a way that putting the rod in is safe. What do I mean by that? When you're doing lengthening over a nail, by definition, the nail is filling certain space in the bone. The wires and the pins don't touch where the rod is, because the rod's there blocking that space. In this case, if there's no rod in the bone, probably those pins and wires are passing through the center where the rod would go. So theoretically, there's a risk of infection, because those pins may have little small bacteria that are normally causing no problem. But when you take those pins out and put a rod down, a couple of bacteria survive and stick to the rod, and maybe you get an infection. So there's some research that says the longer a fixator was on and then you do a rod, the higher your chance of getting an infection. So I wouldn't have a problem recognizing, look, a problem happened. It's out of my skill set or wheelhouse at this point in time to fix it. Keep your motion. Let's get your bone healed. Let's get the fixator off. I hear you that you have knee pain. Come back. We'll re-break the bone. We'll put the straight rod in now that all the holes are healed. And it's a second surgery we weren't expecting, but you got your length. Hallelujah for that. And we'll get your leg straight. So all hope is not lost. Maybe we would have done things differently, but recognizing the problem is important. Trying to prevent the problem is important. And then treating the problem as it's there. So, but 10 centimeters in the
I know.
Wow.
I know. Well, he did mention to me on a consultation that he had to get a soft tissue release at the gastrosoleus recession or Achilles. Yeah, so that was how it was possible.
So when you loosen soft, if you do a soft tissue lengthening, there are different ways to do it. But once you get to the point where you need to do that, you need to stop, because there can likely be permanent weakness as a result of that. So at the Paley Institute, we don't lengthen you to the point of soft tissue release below your knee and your tibia. Do the soft tissue release to continue lengthening. We stop you before you get to the point where surgery is going to make you better. Because if you have to have surgery to get better, then we're doing something wrong. We want you to regain your strength. I will not sacrifice your function or your recovery for length. You may want 3 or 6 centimeters. If you're at 4.2 and we've slowed you down and we've doubled up on your therapy and you're wearing your splints religiously and you are doing everything right, but your body is just saying, I'm done, you're done.
Yeah.
Maybe we take a couple of days off. We take a week off. The bone isn't going to consolidate and we try again. I had a patient today who not a stature patient. She has a dwarfing condition and she got lots and lots of centimeters in her tibias. And we stopped for a week and she loosened up and did great. She did another few millimeters and got tight again and we stopped her. And you know what? No harm, no foul. She safely achieved her goal, will not need surgery to recover. So there's lots of things, 10 centimeters is a lot. Of course, it's too much. You need a soft tissue release surgery.
Yeah.
I'm more bothered by the need for soft tissue release than the axial deviation.
Oh.
Because the axial deviation can be fixed non-operatively if you adjust the fixator. Soft tissue release is surgery, and you may have permanent weakness from that. It doesn't make me happy.
Wow. Oh, wow. That's something definitely.
And one final thing. I have no problem that surgeons in the world are doing stature lengthening with external fixators. They're readily available. They're relatively cheap compared to the price of the PRECICE, but you have to know how to use it.
Yeah. Yeah. And in this case,
one case in this surgeon's repertoire, I don't know, but all hope is not lost. Whoever this patient is, it may be a surgery you weren't planning on, but you got your length, recover. They will get your leg straight, or come to me and I'll get your leg straight.
There you go. There you go. Awesome. Very cool. Very cool. All right. We're going to move along to the submitted questions section here. And these are the patients that when I put this out there that Robbins was coming on today, you guys sent in your questions. And most of the questions were about the PRECICE Max. That's right. Yeah. So question number 1 is, when will the PRECICE Max be available? You mentioned this earlier, but there was a lot of people.
Quarter one, 2024. So sometime between January and March of 2024. Okay. When it becomes a known date precisely, we will announce a worldwide blast.
Yeah. In fact, Dr. Paley is going to probably come on for that. So
yeah.
I'm sure.
I'm probably going to tell you before. I'm going to hear about it from you. You're just going to DM me. Hey, I heard Max is coming out on, whatever. I'm going, oh my God. Yeah.
Right. All right. Question number 2 was, do you know what its weight bearing capacity will be? How can titanium hold up compared to the PRECICE 2.2? What's the difference?
So I have in front of me some information.
Yeah.
I'm not sure, what of this I can show. So I'll just say, so there are nail diameters of 10. So we're talking about tibia. What am I looking at here? Tibia and femur. 10. These are all millimeters. 10, 11 and a half, 13, 14.
Okay.
And the weight bearing capacity for the 10 is 150 or 69 kilos. For the 11.5 is 200 or 91 kilos. For the 13 is 250 or 114 kilos. And for the 14 is 250 or 114 kilos, which makes sense. So again, let's go back to what I was saying earlier. If your body height is shorter, your bone tends to be shorter and therefore narrower, so therefore the narrow nail fits.
Right.
If we equate body weight somehow related to height, in general, a taller patient is heavier. A taller patient, bigger bone, bigger nail, holds more weight. Yeah. So put all this in perspective. The smallest diameter for the PRECICE Max is 10 millimeters, and that will hold 150 pounds, which is 69 kilograms per leg. So standing, it's doubtful there is a 300-pound person having stature lengthening, but each leg could hold 150 pounds. Yeah. So, could you walk? No, because the rod, it's not. Maybe calling it a full weight bearing nail isn't the appropriate thing, because if you weigh more than twice what the nail can do, you can't walk on it. You can stand on it. So the idea is this is a tool that allows you to bear more weight. If it's safely within the manufacturer's recommendation, you'll be able to walk. The vast majority of our patients, based on past experience, the shorter patients are lighter weight, the larger patients are bigger weight. The vast majority of our patients will be able to walk with this nail. So what can you do to prepare yourself for surgery?
Yeah.
If you weigh 200 pounds and you're 5 feet tall and you're probably going to get the 10-pound nail, do I think it's wise for you to lose 50 pounds in the next month to have surgery? I do not. I think you have to ask yourself, based on your personal fitness level and your body habitus, God forbid we want to do the PRECICE Max, but it won't fit. And we, again, in our institute, there's not going to be a surprise. If we don't think it's going to fit, we're going to ask you, do you want us to put a rod in if it's not the PRECICE Max? If I'm not positive I'm going to put in the PRECICE Max, maybe you don't have surgery with us if you don't want the PRECICE 2.2. Yeah. Imagine if you wake up and for whatever reason we have to put a PRECICE 2.2 in and you can't be full weight bearing. Do you have the strength in your arms?
Yeah.
Oh, did you forget to mention that you have rotator cuff pathology and you can't even do a push-up? You assume you have the PRECICE Max. Surgery went perfect. You have the biggest rod they ever made in the history of the universe, but for whatever reason, your muscles are sore or you just intellectually can't put full weight for the first week or two. Do you have the ability to use crutches or a walker? Because you may need to, maybe for one day, but maybe for 3 months. Yeah. So what can you do? Sort of assess yourself. Do you have the upper body strength and dexterity to use crutches or a walker? Because you may even need it just to get in and out of the car for 2 weeks. But if you can't do it, that's some prehab. That's some work you can do before surgery. Should you get 50 pounds off in a month? No. But if you look down and you got a little bit of tummy on you, maybe as part of your prehab conditioning before surgery, 15 or 20 pounds will come off in the next couple of months. That's pretty safe. A pound a week is pretty safe.
Okay. Very cool. Yeah, definitely, guys. Like I said, getting strong before surgery. You don't have to stop completely. Just, focus on flexibility a lot more, but keep those muscles strong. Very cool. All right. The next question is, we've talked about the nail sizes. Patient kind of asks, are patients liable for PRECICE Max malfunction? Say that, it just
we haven't had one yet.
So he doesn't know.
Let's be clear. The mechanism, the drive mechanism for PRECICE Max is the same as PRECICE. Thousands of PRECICE I've put in. The number of PRECICE nails that I've had a true mechanical malfunction is so... I can think of maybe 3 in 9 years out of thousands of nails. It's that rare for there to be a mechanical malfunction. If the malfunction is due to the fault of the nail, if you come in and 2 of the screws are broken and your 3 centimeters has collapsed, that's not a nail break. You have to overload your screws to break 2 of them. So there's more to the story than you're saying. If you fall down the stairs and break your leg, it's unfortunate, it's terrible, but that's not the PRECICE Max's fault that happens. So the nail doesn't exist yet, so I can't answer that question. But if there's a true malfunction, you will not be liable. In the very rare instances where a PRECICE nail malfunctioned, there was not in the Paley Institute, there was not a charge to the patient to replace that nail. It's a surgery and it's unfortunate. I have donated my surgical time for a handful of patients to have had to have unplanned surgeries. I charge no fee, depending on whatever the circumstance. Now, segue, there can be problems and complications that happen after lengthening surgery, whether we expect them to happen or not. And so we tell our patients that you should have some cash reserve in the event one of these rare things happens, whatever they may be. But again, try to prevent a complication. You can't prevent a nail malfunction. I'm getting a little bit off the topic. But if the nail is truly not working, I don't think you'll be liable for that.
Very cool. But yeah, guys, like I told you way back when in the video, I said keep a complication fund just in case. You never know. So we actually kind of answered number 5 before about the advantages of a weight-bearing nail versus not for stature lengthening. So we're going to go ahead and move on to the page 2. This is actually kind of like he was asking more sort of towards your patients. How many of your patients lengthen over 6.5 centimeters? And we're guessing the femur.
So how many patients wanted 6.5? So I'm going to change that question because I feel like I have prerogative. The way I interpret that is how many patients are getting more than 5? 6.5 is definitely more than 5. if your goal truly, like you understand this process, you're 3 weeks into it and your goal is 8 centimeters. If your goal is 8 centimeters, there's a pretty darn good chance at the Paley Institute you're going to get your 8 centimeters.
Yeah.
Why? Because every day your therapist is evaluating you. And if you're getting into problems early, I'm going to know about it. And we're going to talk about strategies. You got to stretch more at home. Maybe you pick up more therapy. If you're doing more formal therapy, someone's got to pay for it. You're going to pay for that. But there's lots of things you can do. Maybe you have your sister come down and stretch you an extra hour a day, your brother, your boyfriend, your girlfriend, your mom, you hire somebody. More stretching is more better. So I interpret that question as how many people are reaching a goal, even if it's a high goal, and the vast, vast, vast majority of patients are reaching their goal, whatever it may be.
Wow, that's very cool. That's good to hear, reassuring, definitely. Okay, so we kind of answered number 2 a little earlier about the ideal length for femurs. He said about 8 centimeters max. Number 3 is when to consider quadrilateral limb lengthening. So a lot of patients, prospective patients specifically, they're always like, I want to get 5 inches in height. They do this before the first surgery, but when is it realistic for a patient to consider the second surgery?
I got you. Okay, so let's just take that statement and blow that up. God, do I want 3 inches or do I want 5 inches? I don't know. The fact that you're just asking, not you, Victor, Cyborg. Yeah. The fact, if someone asks that patient, and I don't want to use the word flippant, but flippantly, should I do 3 or 5 inches? You're not understanding the process. You're not understanding what it actually takes to just get 3 inches. Let's be very clear.
Right.
This isn't deciding to cut bangs or not. This isn't deciding to have a facelift during the lunchtime facelift. I know nothing about breast augmentation, but I'm sure whatever the volumes are, this isn't this size with this size. This isn't, hair extensions or not. This is major surgery that should not be taken lightly. There is no such thing as maybe I'll do 3 inches, maybe I'll do 5 inches. It is an entire second round of bone cutting surgery to get more than 3 inches, however you want to look at 3.1. Let's be technical. 8 centimeters is 3.1 inch. The max you could get is what the nail can do is 8 centimeters. And let's say you're fortunate enough to get 8 centimeters safely and everything's great. You can't get more without doing another surgery. If for whatever reason, the risks, you understand this is a major undertaking, and you just know in your heart, in your soul, in your mind, 10 centimeters or 9 centimeters is my absolute minimum. I have the time now. I don't have time to come back next year. I can't do part of it now and come back. This is one and done because I have to go on with my life. And you need more than 8 centimeters, then it's 2 surgeries.
Okay.
The question you then have to ask yourself is, do I want to do that combined at the same time with the maximum potential, hopefully of 10 centimeters? Or do I want to get the most I can on my femurs now and then come back and do tibias? And let's break those down. Cost, expense, risk for 8 centimeters femurs versus cost, expense, risk versus 2 extra centimeters by including the tibias. Ooh, twice the risk, twice the cost, twice the, fill in the blank. I don't know. That's hard. Another way, right, because I'm blowing this up, another way of thinking about it is what's the functional difference or what's the aesthetic appearance difference of 8 in the femur versus some in the femur and some in the tibia? Because if you do some in the femur, some in the tibia, in theory, you're keeping the leg proportions pretty close to normal. But remember what I said in the beginning, the proportions don't really matter.
Right. Yeah.
Most everybody's coming to us with normal proportions. And if your proportions are off, so we had somebody who came in yesterday or Monday, and her proportion was 76% and 78 is normal. That equates to if her tibias were 5 millimeters longer, she would have normal proportions.
Wow.
Well, we're not lengthening 5 millimeters. We're lengthening 8 centimeters or 7 centimeters. So that 5 millimeters means nothing. Does that make sense? Proportion is just a number. So another way of looking at this is I can think of one patient. Again, we'll ask our patients who are not happy with the length they gain. Why? Because in our institute, I'm going to see you every 2 weeks, and I'm going to say to you and ask you, do you notice that you're taller? And as an aside, it usually takes between 2 and 3 centimeters where everybody says, oh my gosh, I am absolutely taller, whether, 1.25 inches, 2 or 3. But that's about where almost everybody across the board. is like, holy cow, I'm actually doing this.
Right.
So I ask patients, do you look in the mirror and see your legs? When you sit down in a chair and you look at your legs, do you notice they're getting bigger? So it's in your mind. I don't want it to be a surprise when you get to 8 centimeters and you finally look at your knees and go, oh my gosh, my legs are too long. You know, we've had one patient I can think of who at the end of 8 centimeters wanted his femurs to him look longer, so he did tibial lengthening.
Oh, wow.
It was his thing. But that's one in hundreds, because
Right.
we're going to always ask you and remind you, I'm going to help you get to your goal safely, but you have to know what your goal is. And the way you're going to know is you're going to look in the mirror every day and you're going to evaluate. Because the aesthetic part, some people want very long femurs, some people want very long tibias. That's a key part, but that's your personal part.
Absolutely. And I tell them all the time, I say, hey guys, it's not about the numbers, because numbers don't really matter. I say it's about an aesthetic appearance and, you know, how you look on site. How do people see you, perceive you in public? So that's 100% what it is.
And the reality is, and again, we can ask our patients, because I get the benefit of seeing you before you go, and then I see you a year and a half later when you come back, and I ask the same kind of questions. Are you happy you did it? Yes. Would you do it again? Yes. You know, would you recommend it to a friend? Yeah, your vast majority, everyone's very happy with the decision that they made. And I asked, did anybody notice? Well, the first couple of months while you're learning to walk better, yes. But a lot of patients, most patients will choose to do this between jobs, between moves. They sort of have logistically decided how they're going to keep this from their friends. So when they reintroduce themselves as a taller person, you know, oh, where have you been? Like, they don't notice. But I have not yet had anybody say to me, somebody asked me on the subway, did you have femur lengthening? Because your femurs, like, it's never happened. You know, as it becomes more common, who knows, maybe people start noticing. I don't know. I've seen 2 of my patients in public, but I recognize them by their face, not that I thought they were walking awkwardly or they had some weird disproportion. But I also haven't lengthened somebody's tibias 10 centimeters. I think I would notice that from across the room. Because we had a patient who had 11 in his tibias, developed huge valgus, open infections on both sides, and we got him fixed, cleared the infection, got his leg straight, but he's 11 centimeters taller, and he looked like he was on stilts. But he was so happy. He knew what he was doing, and he got his 11 centimeters elsewhere. So I don't even know if I answered your question.
No, you definitely did. You definitely hammered it home. That was awesome. But yeah, real quick on that same point, I actually want to talk to one of your patients here. We'll do that briefly. Brett, you are on the show. You've been on the show many, many times. You're actually one of Dr. Robbins and Dr. Paley's patients. So you actually got quadrilateral lengthening done. Many patients know you. You're a fan favorite here. So can you actually talk about that point number 3, getting quadrilateral lengthening, talking about the proportions and how you feel now?
Yeah, sure. So, you know, going to the Paley Institute, this was all a very new process for me. Can you hear me okay?
Yes.
Yeah, we can hear you.
Okay, cool. A very new process for me, but obviously they were very professional, went through what am I getting into, what am I doing. A lot of knowledge, because I did look into this many months in advance, of course, to try to learn, but just learned a lot from them. It's all according to what you want. You know, I wanted to do quadrilateral. As I told Dr. Robbins initially and Dr. Paley, I want to do 8 and 8, you know, but Dr. Robbins was like, well, you need to do the 4 and 4 first, you know, before you even think about that. You know, you got to figure out. So, you know, I've gotten through the 4 and 4 now. And I mean, it wasn't easy just to get 4 and 4. So he was definitely right about that. A lot of endurance and getting through things, but it's up according to what you want. You know, you have to decide for yourself, and he will tell you what you're getting into, and you got to be prepared to go through it mentally and physically.
Now, Brett, can we talk a little bit about like the proportions and how they look when you look in the mirror in the morning? Because you got it done 4 and 4. That's a really proportional interlimb ratio that you maintained. How do you feel about your proportions?
Honestly, I think they're great. I don't think I look that different. I mean, I don't really notice it looking weird or anything. It feels very natural to me.
Yeah.
So.
Yeah. Awesome.
Go
ahead.
Brett, are you going to have second round of surgery?
That's my plan. I'm trying to do that next year. So
fair enough.
Just
interesting to know. And then here's a question: would there be any reason where you would want to do more than 4 and 4, even if you knew you were going to come back, like to try to get 9 total, maybe, or 10 total, and then maybe you wouldn't come back? Like how did you decide stop at 4 and 4?
So my thought process was, I know the max I can get is 8 and 8 out of everything. And of course, you guys make us stop at 5 in the tibia anyway. So since my max is 8 and 8, I went with 4 and 4. And I kind of wanted to use this as almost a test drive.
Mm-hmm.
So I wanted to see how I recover with the 4 and 4. So I've been playing basketball, I've been playing sports, I've been running, and everything's been great. So since everything's been great, now I want to go back and do the rest. But obviously I can't do more than the 8 unless you give me a different nail, and I don't want to take the risk of that. I feel like since everything's inside of me, I mean I know no surgery is easy, but it's all inside of me, and while it's all in me, I'm never going to have the chance to do this again, because when I get these taken out, I'm never dealing with this again.
So, and just to make it clear, we don't automatically stop you at 5. Let's be very clear. How many patients doing quadrilateral have gotten more than 5 in the tibia? I'm sure it's happened. Honestly, I can think of one in the last 9 years. We don't arbitrarily stop you, but to your point, what you were saying is, if you think you're coming back anyway, and very good chance, why do more than half the length? The problems typically don't start 1st, 2nd, 3rd, 4th centimeter. They typically start in the later centimeters. If you can only get 8 total and you're having 2 surgeries, getting 5 now and 3 later doesn't save you anything. So stop at 4. If you're doing tibia lengthening only and your bone quality is good and your alignment is good and you're happy and you can stay for longer, we'll go till it's not safe to go anymore. The vast majority, it's 5 or under. So just to be a little bit semantic, we don't hard stop you arbitrarily. But all of these go into the computer in your brain to decide what you're trying to do. So sorry to jump over you there, Brett.
No, it's all about safety. It's all about safety, guys. Yeah. Very cool.
Hopefully I answered your question.
Yeah, you definitely did. But I actually have another guy here that I want to take a different perspective from. Rio is here. I think he's actually a new patient. He just had surgery done recently. Rio, welcome to the show, man. Can you hear us? Hey, man. How are you? Is your audio on?
I know this guy too. Can't hear him.
Yeah. Maybe he's going to rejoin. He'll rejoin in a little bit. I wanted to get his perspective as a recent patient. Would he think about another limb segment? But we'll come back to that later. Dr. Robbins, we're going to pick up here for the last couple submitted questions.
Sure.
This is about the mechanical nails. Some surgeons who are using this abroad, they're doing a 1 centimeter or probably 0.8 centimeters of intra-op lengthening with the clicking mechanism. Is this something that the nerves? What's that? You don't know why?
Why?
I guess I don't know if they're just testing the nail or what, but they say that they do this. Do you know if the nerves can tolerate that much all at once?
Yes, they can.
Okay.
But that does a few things. One, if you want to prove the nail works, you don't need a centimeter to do it. Two, we do this thing called so we test all the nails. Every nail, 100% of the nails, we test 1 millimeter. If the bone breaks, there's a certain displacement, we test the nail 1 millimeter and leave that. We don't reverse it back down.
Okay.
We wait a week till we start lengthening. We call that the latency period. And the idea is that during that week, your body has a broken bone, and it doesn't care whether it was from falling out of a tree or hit by a motorcycle or basketball injury. The bone is broken, the chemical mediators are there, and the healing process starts. The whole point of pulling the bone apart in what was Codavia back in the 1890s in Shantz and then Elizarov in the 1950s is tricking the bone into healing, but then pulling it apart. And then tricking the bone into healing and then pulling it apart. And that's what this distraction osteogenesis, bone healing, or distraction histogenesis, all the tissue healing. You're tricking the bone into healing, but then you pull it apart so it can't join the gap. So if you pull it apart a full centimeter, you just kind of negated that. So I don't understand the need. I don't understand why they do that. So I don't have much more to say about that.
Okay, very cool. All right, so we have Rio here. Hey, Rio, can you hear us now?
Yeah,
cool.
I can hear you. Can you hear me now? Okay,
Yes.
I can hear you now. Awesome, man.
Great. Hi.
So, welcome.
Yes.
Welcome.
You yesterday.
Yes, Dr. Robbins. Yes.
Yeah.
You're my favorite doctor here.
Yeah,
I'm
we
the
just
best
heard that
doctor
you.
on the forum tonight.
Yes, yes, of course. Thanks
Welcome,
very much.
man. So congratulations on your recent lengthening. So how far into your lengthening are you?
Exactly. So I'm doing a 4 segments at the same time, and
Okay.
I reach a 4 centimeter for femurs and actually 3.9 for tibia. So literally like 8 centimeters. Two
Wow,
more
you're really
centimeters to
far
go.
along. That's
Yeah,
incredible, man. How are you feeling?
yeah. I mean now it feel great, but post surgery, so a little bit, need to deal with the pains and rehabilitation. But all my like therapy supporting as well as doctors, so I feel great now.
You
Yep.
feel great.
Let's be clear. So his surgery was the most recent, so it's very fresh on my mind. He had a pretty good recovery. He is excellent with his therapy, and he works very hard. Same thing with Brett. You have to be invested in this product. Not just the finances, it's time, it's money, it's
Mhm.
away from your family. You're losing your independence. You're eating hotel food. If you're not going to come here and be all in, then you probably shouldn't be doing this. And tell me if I'm wrong. You put your
Yeah.
work on hold, you put your life on hold, you put your relationships on hold. Your job is to be a limb lengthening patient. It's not to come down here on vacation and run your side hustle 4 hours a day on a laptop sitting in a chair. You're here
Right.
for limb lengthening. And all of these people I think can attest to that.
Very cool. And we have another one of your patients here who's been on the show many, many times. SG, welcome back to the show, man.
Hi, how are you guys?
Good, man. It's so great to have you back. Now, we know that you came on throughout the summer talking about you wrapped up your lengthening, but you're still in that recovery process into the consolidation phase. Can talk a little bit about where you are.
Yeah, sure. Actually, I'm almost reaching the 8th month after surgery. I got my surgery in February, so now I'm walking. Still not a normal walking, but walking. I'm feeling every day better and better. Actually, I'm gaining the endurance of the muscles, because one thing I didn't realize is that being 3 months in a wheelchair, you lost, or your muscles get atrophied. So when I start walking, I thought it will be easier, but not. But it's still better and better every day. I'm really happy with the results. And as everyone said in this show, it's a full commitment process. And I will add that it's not a 3 month commitment for me. And talking just about, well, for me, it's like 2 years commitment to being the same person as I was before. I think I am the average person. I don't heal faster than anyone, or but I heal as average as Dr. Robbins told me. So I think like the times I start like walking almost at the 6 month, and well, here I am happy. I reached the 6.5 centimeters, and actually, as Dr. Robbins said, I remember when I was in his consultant room, and he told me if I feel taller, and for me that switch of in my mind, that one thing that I felt short was like after I reached the 5 centimeter. After that, for me it was a life changer surgery, and now I don't feel short anymore. But it's full commitment. It's a serious procedure. It involves pain, but after the results, you will be happy with the results.
That's
And just
awesome.
I want to clarify something. So he's saying it's a 2 year commitment. What he didn't say is that he runs a 2 hour and 45 minute marathon, right?
Yeah, that's your.
Yeah. So let's be clear about a couple of things here. This will never make you a better athlete, right? We don't do this to make you a better basketball player, whatever. If you are a high level athlete, we expect it's going to be 2 years for you to get back for a couple reasons. One, because there's just the recovery of the atrophy, but two, that's 2 years you haven't been running, and you've probably been running since you were 4 years old, 30 miles a week. So I am so anxious to know, because he's got a good metric, a year, 2 years, 3 years from now, if he decides to keep running and doing those long distances, how his times are going to be. So anybody who's going to take the time and share their story, I think, has even more commitment to this. So I don't think anybody on this is one of our average people. I think you guys are all above and beyond the typical patient, which is wonderful. Thank you so much for sharing your personal stories, because you really put a face to this process. Victor and I can call back and forth about the logistics of it and who should do what, but here you guys are actually sharing your story, and you're doing it. You did it a year and a half ago, you did it 8 months ago, and you just did it a couple of weeks ago. It's kind of cool.
It definitely is. And Dr. Robbins, something that you may not know, a lot of these guys over the last couple months have shared actual videos of their recovery. Like Brett shared his running video on the treadmill, on the sidewalk, looks incredible. Even Brett, I think you showed something of like you're playing basketball. And then SG showed some of him swimming. These guys are like really, really kicking it up. Yeah, they're doing it, man. So they're out there recovering, and it's looking great, and it's showing what you guys do there at the Paley Institute. So it's incredible. All right, let's see here. So we do have one more page of submitted questions. I know we're going to try to get through these. There are only a couple of them, then we're going to get into the live Q&A. Okay. All right, guys. So this is actually asking about when the PRECICE Max will be released in Europe, your European patients.
No idea. No, I can't even guess. Sorry. Next question. Yeah.
All right. Was there any clinical trial testing for the PRECICE Max? Will there be any before the release?
That's a good question. So I will have to let Dror answer that, because he's on the design team, and he's more. I am not involved in the design decisions or the FDA approval process. So whatever the process is to test a nail and get approved to officially use it, that is being done currently. Whether that's a clinical trial or whatever else the FDA deems is important, yes, those things are being done.
Absolutely. And guys, just so you know, like Dr. Robbins says, Dr. Paley is the chief surgeon on the design team. So if other clinics have said that they know something about it, or, they think that they know a little bit more about the nail, I wouldn't necessarily take that for fact. I would wait till Dr. Paley comes on sometime when the nail release is about to happen, because he will speak on it, because he's the guy on the design team. So
yeah, and it's going to have a limited release, and we're obviously going to be, I don't know if we'll be the only one, but one of the first centers.
Oh no, he actually emailed me. He said that you guys will be the first to implant. So
there you go. Okay.
Yep. So all right, and then the final one is should a patient, I guess, pretty much see some patients get the PRECICE Max before they get it themselves?
So we can ask our 3 patients here. We have a nice representation. If you could be the first patient to get it, would you get it? And I'm guessing 85 out of 100 of our patients would sign up to be the first patient to get it. There are a small number here to, let them put 50 or 100 or 200 in before, but it's the same drive mechanism. So the expectation is there's not going to be a problem. The reason the other weight-bearing nail by this company was recalled had nothing to do with the working mechanism and had to do with the metal. This metal of the Max is the same metal as PRECICE 2.2. There's just a little bit more of it. So it's the same mechanism. The expectation is that it works exactly the same, and there's no differences except you can put more weight on it, more metal made it stronger. So, yeah.
That's very cool. So it's the same type of metal, titanium, and same result probably.
Yeah.
All right, guys. So before we go into the live QA, I actually want to, we do this for all the clinics that come on here. So the Paley Institute, I just want to kind of ask Dr. Robbins, he works there every single day with all these other, I think it's like, was it 23 surgeons?
I just counted. I don't even know. When I joined on June 1st, 2014, so I was 9 years in practice, and then I came to George trained me in 2005, and then I came and joined him. It was 2 of us.
Yeah, that's it, just 2, and now there's multiplied to like 24. It's crazy. But yeah, what's happening at the Paley Institute? Anything new? What are you guys expanding on?
Yeah, so it's what we do, but on a bigger scale. So Dror and I, we do congenital, we do adult, we do post-traumatic, we do stature lengthening. But those aren't the only things that exist in orthopedics. There are people who do joint replacement. There are people who do arthroscopy. There are people who do sports, foot and ankle, hand, spine, non-operative spine, whatever it is. We got all of them. It is such a cool group of people, and not just the clinicians, right? So, the pilot on the airplane, hey, this is Jane, and I'm your pilot, and that's great. And everybody, oh, Jane, thank you for flying us. But the ground crew's part of the thing, and the ticket agents are part of the thing, and the baggage people are part of the thing. It's just the pilot or the astronaut or the quarterback or the surgeon sort of gets the praise, because we may be the face of the team, which is nice. But all the weight and responsibility comes on our shoulders too. But we're good at what we do because of the team we have. And I can't say that enough. On the call with us are Angelique and Lena, and these 3 guys can tell you they've probably talked to them hours. Well, Lena's newer with our team for Stature, but Angelique, everybody knows Angelique. She spends hours and hours and hours answering questions And as I know is true, but she'd never complain, answering the same questions over and over. They never complain about anything. It's amazing. So our team isn't just the surgeons. We are as good as we are because of the team we have. Our admins, our schedulers, our x-ray techs, our surgical techs, our OR techs, our product representatives. We surround ourselves with greatness and everybody rises to the task, and it's really great. But what makes this work is physical therapists, and not just because my wife is in the background. It really is. Even a patient who's not wanting to be that helpful for themselves in the beginning, and even with a surgery, let's say it could have been a 98.6 and it was a 98.4, whatever that scale means. With good therapy, a lot can be overcome. The therapy, and that's why we have you stay with us. We are protocol driven from how we do the procedures. We are protocol driven from how we do the x-rays. We are protocol driven from how we do the therapy. Why protocols? Because they're proven and they work. We adjust them over time and experience. But if I know the protocol for therapy and a therapist calls me, I know we're on the same page. If a therapist calls a physician assistant, they are on the same page. We all speak the same language. We are purpose built for you, for stature lengthening. So that's kind of going to your number 2. Why are we in the world? Because this is what we do. We are built. We have infrastructure, people, protocols. It's what we do. And that's all, a testament to the guy whose name is on the door. He built this. And it's really pretty cool to be part of it.
Absolutely. And I mean, like you said, the surgeons that you guys have there, growing team every single month. I see a new face pop up when I check the site. And then the physical therapists, I think you guys have a team of over 30 some physical therapists now too.
I think it's more than that, including PTAs. I think we're way more than that. It is. So we moved into a new building in the last 2 years. There's therapists everywhere. It's so cool. It's so cool.
Yeah, so you guys will be definitely hitting your goals easy. All right, cool. Now, for number 4, I was going to ask you, but I think it would just be better just to ask the patients that you have here. So, Brett, let's start with you. So, when you were selecting a surgeon for your limb lengthening procedure, why did the Paley Institute stand out to you as the go-to clinic?
Yeah, so, I did a lot of research. Well, honestly, one thing is they were a closer distance for me to drive there and everything. But, Florida, I mean, it was, when I did this, it was later in the year, getting into December. So it was warmer and all of that. But minus the logistics, just the track record. I mean, if you look up reviews on Dr. Paley, he's, the best out there. So, I'm like, Dr. Robbins said this was a very serious surgery I was doing, and I did 2 of them because I did tibia first and then femur second. So, you're getting put under anesthesia, it's very serious what you're doing. And I wanted to make sure, to the best of my ability, I was trying not to let problems happen. So that was my choices for all that. And as far as going through the process, talking about the physical therapist, I like that there are so many physical therapists there. So I had the option to try different ones, because with physical therapy, there's a lot to it, right? Because I had injured myself playing sports before, but this is very different. You're really stretching very hard every day, and it's restarting every day from scratch. And it's not just the physical therapists. Like, some of their personalities might be better with you for some, but also just maybe their techniques. Like, they all can do same things in different ways, right? So I like that I could try different ones and find the ones that really worked with me, with what I was going through, and just learning the knowledge. They all have so much knowledge, so you learn from each one different things that you would never know to even try and do. So yeah, the physical therapist is the main part of when you're going through stretching your muscles and the pain there. So
it's a major important part of this process. Yeah, absolutely. All right, so let's go now to Rio. Rio, can you kind of tell us why you selected the Paley Institute as your limb lengthening clinic? Did he go to the bathroom? Let's go to SG. Are you still there, SG?
Yeah, sure. Here I am. Well, I visit like 3 clinics or 3 hospitals in in the United States. For me, well, yes, it's the track record that the Paley Institute has. Also, for me, it was like it's a serious surgery. So I look at it as an investment in my life to feel like really good with my body and how I have the perception of myself. So I need, for me, like the best option that I feel a place that I can feel secure, that I can feel comfortable. And as I went there, I like got a lot of feelings after the consultation that I got. Also, it was that it includes the physical therapy. That for me it was very important, actually, because I am from abroad, from abroad. So I think that that was a plus for me. That it was like all things in the same place. So I don't have like to do as Dr. Robbins said, that just be a patient that has been all in the process. And I think all the personnel, all the staff, and all of the surgeons like give guidance through the process. I mean, it's an unknown territory. This the thing it's like every day it's something new. So for me, that guidance was like a really important thing to choose the Palings.
It's awesome. Very cool. And Rio, are you back yet? Are you awake? Not yet. All right, we'll come back to you, Ria. I know you probably fell asleep. I'm taking forever, so we'll move along. But anyway, Dr. Robbins, that was amazing. So now number 5, I think this is cool. We're gonna have Dr. Paley talk a lot about this too, because he's expanding. But you know about this a little bit. So you guys have 3 locations right now that are in full force. We have the West Palm Beach, which is where everybody here is. But you also have the Poland and now the Abu Dhabi clinic. Can you talk a little bit about them, and are they doing taking stature lengthening patients?
Yeah, so I know some have been done in Poland. I'm not sure Abu Dhabi, because Abu Dhabi is the newest. Angelique can jump in if she knows more about me. I have not operated in Poland or
Okay.
Abu Dhabi, so I don't want to say anything wrong or confusing. So I'm going to opt to table discussion of Poland and Abu Dhabi. You get it straight from the horse's mouth with Dror. I
Yep.
can speak very clearly about West Palm Beach, but not the others. So I apologize. I don't have a good answer for you on that one.
All right. Well, we'll have Dr. Paley on in the next 6 weeks or so. Very cool. All right. So let's go ahead and see what we got next here.
Yes, we
Yeah. Is that Lena? Lena, is that you? Hello, Lena?
yeah, this is me.
Yeah. So
Yes, can you
what
hear
were you
me?
saying? Yeah, I can hear you. What were you saying? I'm sorry.
Hello?
We can hear you, Lena.
Yeah, I say we had 1 or 2 surgery.
In Abu Dhabi, you had 2. You know what? That's actually true. Yeah. I actually know. Yeah. And yep. So there have been 2 patients there that got done in Abu Dhabi. So very cool. That's awesome. They just opened up. I think if you guys check out their Instagram, you can go scroll back and you can see like when they let down the drapes for the Abu Dhabi clinic. They look really cool. So yeah, go check it out. All right. Moving along. Finally, guys, this is episode 100 of Limb Lengthening Live. I know it's a long one, but that's what it's all about, is jam-packed, value-based knowledge, and that's what we have Dr. Robbins here for. So he is going to do a live Q&A right now with you guys in the chat. So what I'm going to do, I'm going to actually post the join link. So if you guys want to come on live and ask him vocally your questions, that'll be the easiest for those of you who are brave enough to ask a world-class surgeon your questions. But if you're not, I'll just pull them out of the chat slowly. So let me go ahead and do that now. But let's go ahead and pull the first question up in the chat just so we can get it.
Yeah, I've been scrolling through. I have some. So someone asked, so it's all magnetic, no radiation. What sort of osteotomy? We do vent the canal. We drill through a 1/4 of an inch incision or a 1 centimeter incision. Is how we do the bone cut. So we use a drill to make small holes, and then we use an osteotome. Okay. What makes it weight bearing? If it's the same material, it's just the way they designed it. They made thicker walls. So the diameter in the nail, maybe they made the components smaller on the inside, but you know, we'll have to ask the engineers. But they made thicker walls, so it's stronger. Awesome. What type of precautions do we have for pulmonary embolism, fat embolism? Figure out. No, these are such rare things. We assume everybody can get pulmonary embolism or fat embolism, and we do things to try to prevent them. But most importantly, we know they exist and we look for them. We did a study on this, and if you look in the medical literature on fat embolism, most fat embolism is associated with patients who have huge trauma. car wrecks, motorcycle accidents, because a lot of bones are broken, a lot of bone marrow with fat is released into the blood system. But they may also have bruised their lungs with broken ribs. So it's very hard to tease out fat embolism from an isolated surgery like this where there's not trauma involved. So we actually created our own criteria after reviewing lots and lots of patients. So anyway, our incidence of some form of fat embolism is about 4%, but the vast majority of patients don't know they're having it. We know because we monitor you in the hospital with a little probe on your finger called a pulse oximeter. And whatever the numbers are, you may be sitting there eating, drinking, talking, don't even know your oxygen is slightly lower. So we treat you with oxygen, and the vast, vast, vast majority of patients, an extra day, they get better on oxygen. We've had 2 patients get fat embolism syndrome, where the fat overwhelms your body's ability to clear it, and they got critically ill, death's door ill, the ICU ill, 3 weeks, 4 weeks, 6 weeks. Very, very, very sick. You can die from fat embolism. Both, we think, had an association with vaping that wasn't very forthright. They both happened during COVID. So, these are such low number events. Statistically speaking, they may have been the 2 out of 10,000, so it's very scary. It's very real. And that's what I'd say about that.
Absolutely. So yeah, that's what you just answered. I just wanted to kind of pull it up there. But this is the next question from Davidson. He was saying, how feasible is it to do remote work while you're lengthening? How have other patients dealt with working remotely and managing their
we kind of talked about your job isn't to remote work. Your job is for stature lengthening. If you must sit in a chair to remote work, your hips are bent, your knees are bent. Let's assume you're femur lengthening. Hip flexion contractures, knee flexion contractures are what happens with stature lengthening without sitting in a chair all day long. So why would you invite that on yourself? So the first few weeks, don't do it. Don't plan on it. Truly have somebody who can run your business for you. After the first few weeks, you'll know how you're doing and you'll know how you are with time management. Do you have enough time to stretch for a few hours, then work some, then do therapy for a few hours, then do work some. It is feasible. Can you guys hear the dogs in the background?
Yeah, I hear that's so cool.
Something's happening. Our dog and my in-laws' dogs are here tonight. So yeah, it is feasible, but it's not ideal. At least the first few weeks, have somebody else who can do the lion's share of decision making and work. And after that, if you got to work to make a living, I'm not judging you, but my evaluation of you has nothing to do with how much work you did. It has to do with how your bone quality is, how your motion is, and my report from the physical therapist. And if your therapy is suffering, you may not hit your goal, or we may slow you down, or we do other things. So your job is to stature lengthen, not work, but I certainly respect if you have to work. It is feasible. It is possible to do, but we have to find a happy medium. It's less likely to do it if you're doing quadrilateral lengthening, and we can ask Brett that. Do you think you could have worked 3 hours a day in between your lengthening sessions going to and from? Yeah. Probably easier to do with 1 segment lengthening than with 2.
Okay. What do you think, Brett?
So I'm a developer, so I work on a computer, but like he said, you can't sit up like at a desk and expect your legs to lengthen correctly and not be tight. So I kind of had to make sure I get up a lot and sit in certain ways so that my legs can be straight and not get too tight. You'll feel it very quickly that they're getting too tight when you're working. But I think you can do it if you're like a developer or something like that, but it's still pretty tough to balance that for sure. I had to work hard on that. So.
Gotcha. What about USG? Working?
And I worked like after the 3rd week of the procedure, but like at 20%. I mean, you also are with painkillers, so you are asleep and it's difficult. And you have to have this straight leg so you can just be like in a desk. So you have to be like in the bed with your computer in your legs. It's not easy, but you can do it. For me, after the 3rd week, after a month, I was working like 50% of the time, and I stay like that. I don't I don't work a full time for that 3 month I was in the lengthening process, because for me it wasn't possible. You have to be like disciplined with being in the PT, then get back, then have some calls, then also PT. And for me it was like 40 minutes all the exercises of PT 4 times a day.
Okay, very cool. Yeah, no, that was very helpful for hearing that. Okay, Dr. Robbins, this is about the PRECICE Max. Do you know the price difference between that and the
So
PRECICE?
we don't know yet, but the number we're using currently is $5,000 per nail. It may be more, it may be less. We do not make money on the nail. Whatever the price difference is will be passed on to the consumer. We're saying budget for $5,000 more per nail. When we have an actual number, if it's higher, it'll be more. If it's lower, it'll be less.
Okay, very cool. All right, this question: do an interview with the butcher, Dr. Stein. Oh, sorry, wrong question. Sorry about that. my finger slipped. All right. This question is from Prakash. He's saying, I had a stride femur lengthening in July of 2019. Stopped lengthening after 6 centimeters and consolidated. Now I want 5 centimeters more. Should I do 6 centimeters more on the femur for a total of 12, or 5 centimeters on the tibia with the PRECICE Max? Thanks.
Good question. So first things first, if those stride nails aren't out, you need to get them out. If they're not out, any lengthy nail that's been in too long. That's a really good question. I stopped after 6. So 11 centimeters in the same bone is a lot. You know, my vote, again, I don't know you. I don't know what you want to do. My goal would be to do tibias next. Again, there's no guarantee. Just because you got 6 in the femurs doesn't mean you're going to get 4 or 5 in the tibias. But I just think 12 centimeters in one bone is a lot. Now, that being said, let's talk about the ability to recover from that. A lot of our patients, the vast majority of our patients, aren't having bilateral leg lengthening, which we call cosmetic stature lengthening. They have a problem in their limb length discrepancy, maybe 20 centimeters or 25 centimeters. If you have a 4-year hiatus between lengthening of 6 centimeters, your body has had more than ample time to recover. So if you wanted to, you absolutely could do 6 centimeters and recover, assuming all things are equal. There's not such thing as too much length in a leg over, a given long enough period of time. So my vote, just all things being equal, would be going for tibia.
Yeah, but definitely get that stride nail out.
Yeah, definitely get the stride nails out. Yeah.
All right, this question from Davidson, he's asking, how soon after surgery can one start walking in the pool? Is it allowable to walk in the pool with the 2.2 as part of rehab?
Yeah, pool is great, whether it's formal therapy where someone's sort of training you exercises, or just get in the pool because it feels so darn good. But it's when your incisions are healed. So all things being equal, it's about 2 weeks after surgery. And getting in the pool is nice for a couple reasons, especially with the 2.2, because once you're up to your chest in the water, you're essentially buoyant, so you can put full body weight regardless of what nail you have. Secondly, the water pressure up at the top of the surface is low, but even at the bottom of a 3.5-foot pool where your feet are, the water pressure will help with helping the swelling. There's more pressure down by your ankles now. Thirdly, just walking through the pool is giving you fluid resistance, so it's getting your heart rate up. Just walking through the pool is contracting your muscles, so you're getting good blood flow. Blood flow is tied to bone healing. Getting your muscles contracting with full weight bearing in the pool means you're contracting your blood vessels, so your risk of blood clots goes down. I love pool therapy. I love being in the pool, whether it's formal therapy or not. So about 2 weeks when your incisions are healed.
Okay, very cool.
Great.
That's awesome. Great to hear. So this next question. Yeah, go ahead.
The pools at the hotels there also have chair lifts that will drop you down in the water, which are really nice.
Yeah, good. Thanks. See, practical advice from someone who's actually done it, right? Just because you're allowed to be in the pool, how do you physically get into it? Thank you for saying that.
Absolutely, because it's like if you have broken legs, how are you going to get in the pool?
Yeah.
Cora says, hey, Dr. Robbins doesn't look a day over 40. Isn't that something?
Yeah, it's all my Botox. No.
Right there. That's the benefit of being a surgeon.
Yeah, I have 4 kids. There's no time for taking care of me.
All right. Here's from Eamon. Hey, I did 4 centimeters on my tibia and ended up with bad equinus, especially with one foot where the talus bone rose up and the fibula hurts when I walk. Oof. It's at 30 degrees after a week of stopping lengthening. Do you think it will resolve?
So obviously this wasn't done by us. We wouldn't let you get to 30 degrees and keep going. We would slow you down, stop you, more therapy, bracing, etc. Whatever. Can't speak to that. The good news is we've had more than a handful of patients who have had more than 5 centimeters lengthening by whatever mechanism at an outside facility. They developed Aquinas, and by the time they've come to us for their femurs or other surgery, it's recovered. So the expectation is, assuming the bones are in the proper positions, which is a huge assumption, because I don't know what he means or she means when they say the talus bone rolls up. So if it's just muscle contracture, it is possible. You just finished how long ago? It's 30 degrees. After a week of stopping. Yeah, you just stopped a week ago. All hope is not lost. We're not rushing you to the operating room. Don't let anybody do soft tissue surgery on you yet. You can always do surgery, but you can't take the surgery back if you've done it too soon. So don't lengthen more. Again, I'm not your doctor. I'm not assuming care for you. I'm sure there's disclaimers I should say. A lot of therapy, a lot of stretching, bracing, etc. It's important, but that's just kind of showing us that's what kind of stuff happens if you're not in an institute where you're closely monitored, you have good protocols. And I don't think any of our 3 patients on here would ever let themselves get to the point, not because they're smarter, but they're more educated, because they came to us and we told them, if you're getting a problem, it includes this. If you can't straighten your knee or move your ankle, it's a problem. You're going to be empowered to speak up and let me know so we can address it. You're not just going to show up a month later with a tight ankle. Well, nobody told me to say anything, because our patients are very well educated. I hope. Let's query them. True or false? This could happen to any of you. Gosh, I hope you all say false.
Yeah, Rio, let's actually ask you, because you just came back on. You're currently lengthening right now at the Paley Institute. Have you had any issues? And if you did you kind of tell Dr. Robbins like ASAP? Rio, did you fall back asleep? Darn it. Brett, go ahead, take that one.
Well, I was just going to say, once again, talk about the physical therapist. They won't let you get by with it either. They're going to notice it before even you don't. So they're going to tell on you and make sure you're in good shape. So
very cool.
We're all on team you, right? We're not tattling. It's not personal. We're trying to assure your time and money and angst are well spent to get the best results you can.
I did actually have to stop lengthening. I think it was just a day or 2 during my process, but it was a huge help. And, it wasn't that big of a deal, honestly. I just missing the day. So.
Gotcha. Sorry, Rio, for waking you back up. I know it's tiring going through lengthening, but hey, man, can you hear us okay? I think the mic went off again. Yeah, he's sleeping.
Yeah.
Rio,
Okay.
Rio.
Can I get a syndesmotics removed by a good orthopedic doctor, or do I have to go? So again, I don't know who you are. I don't know what your bones are. Don't get the screws removed until your bones are fully healed, because if you get those screws removed and the bones aren't, the bones can shift out of place. So yes, any orthopedic surgeon can remove any hardware. The question is, will he or she want to take you on as a patient? But if your bone is fully healed, I take hardware out of people all the time that I've never put in, not just related to stature surgery.
Okay, gotcha. All right. This question is saying, do you think that lengthening over 15% of your initial bone length will, result without repercussions?
I don't know how to answer that. So if someone's bone is 350 millimeters and we do 80, what's 80 out of 350? 20%. So it's not the percentage. We start at 0%, and then we're at 0.5%, and then we're at 1%, and then we're at 2%. So we don't go from 0 to 15%, even if that's your goal. So we go until your body fights back, or we reach our goal, or reach the max of the hardware. So I appreciate what the question trying to ask, but I don't think that particular question has a particular answer. So,
okay, gotcha. Rio, you look like you're popping back and forth. No? Try to go off and come back on. I'll put you back on. It might be the audio issue. Reaper saying, I have nothing to ask Dr. Robbins, but would just like to say I appreciate what he does. Thank you. There you go.
Thank you. Appreciate it.
All right. Let's see here. So this one, we got a couple more questions in here, and then we'll call it a day. Of course, is saying, I've had tibial lengthening 3.5 centimeters on one side with the external fixator. It's been 5 months and still not consolidated. I've used BMAC 2 weeks ago. Is this a delayed union? What can I do for faster bone healing?
Yeah, so technically, to diagnose delayed union or non-union is dependent on looking at X-rays and evaluating if there's bone healing or not. Again, this isn't going to help you what I'm about to say. We wouldn't let you get to that point because we would stop you or slow you down before you got to that point. Anyway, so there are lots of things that can be done. I'm not your doctor. I'm not telling you to do this. But if someone is in an external fixator, things can be done with that fixator to try to stimulate bone healing that don't necessarily involve surgery. What's BMAC going to do? Maybe it's going to help, maybe it's not. Someone have asked us in the past, why don't we do injections into the bone to get them to heal? Because we haven't had to. Just because you can't. Once you stick a needle in there, you run the risk of getting an infection. But why don't you prevent the malunion or non-union rather than treat it? So things can be done. This is way more complicated to answer. I certainly can't give you medical advice. But yes, there are things that can be done without having to do surgery, especially with an external fixator. So at least you have a fixator. That's a good thing.
Yeah.
You want to talk to Angelique and make a consult and send me X-rays. I'm happy to give you my opinion. That's about all I can say about this.
Very cool. Time lapse car guy Bruno said, "Let's get a Groupon going for Stature length. It's so expensive." But this question, I think that's a great idea.
Yeah, there is the. I don't know the numbers, but we've had plenty of siblings come, or father, son, father, daughters, whatever. And yeah, there is a bit of a family discount and a frequent flyer if you had one and you come back for the.
Really?
Yeah, there is.
Oh, see, that's what's not on the menu.
Kind of
so
like a Groupon. That's like you see those things on social media, things you can order off menu at your favorite.
Right. You just got that from the Robbins exclusive there. I love it. All right, Batman Begin says, do you do cosmetic external tibia lengthening with the Taylor spatial frame, or do you have a recommendation for any surgeon that does this because the chance of a fat embolism, pulmonary embolism is lower with this method?
Yeah. So. We would do it. We would, and so TSF. So what this question is asking, would we do tibia lengthening with an external fixator, a hexapod type circular external fixator, not technically an Elizaroff, but whatever, something in the same ballpark, as opposed to lengthening because the chance of fat embolism P is lower. So the risk of pulmonary embolism is the same for both. It's really the fat embolism because you ream and hollow the bone to put the rod in for the nail, but you don't ream or hollow the bone to put the fixator on. So the PE risk is the same. The fat embolism risk is theoretically lower, but our risk of fat embolism is low. We would do it with a hexapod fixator if you wanted it. We'd talk about it. We may be able to look at your X-rays, and maybe you have very wide bones and very little bone would have to be removed, which means your risk is even theoretically lower. So yes, the best surgeon for any limb lengthening is myself or Dr. Paley. Get in touch with Angelique, make a consult, we'll talk about it.
There you go, guys. All right, we're going to take 2 more questions, and then we're going to call it a day. Let's see here. Okay, so this question from Hani, he's actually been on here before. Is there any strength training that you recommend during lengthening, or is it mainly just range of motion and stretching? So you mentioned prehab before, Dr. Robbins. So
again, to answer a question with a couple of comments, anecdotes, and questions. So we've had more than a few patients come to us with a lot of muscle mass, and it's sad to say your beautiful muscles that you've built before this are going to atrophy pretty quickly. It's pretty shocking how quickly your leg muscles will atrophy. So some part of your rehab, as we were hearing, is just learning to walk again, getting your walking muscles back. A little bit of strength training is okay, but it's really flexibility. And another way of saying it is, no patient has ever stopped lengthening because they were too weak. Plenty of patients have slowed down or stopped lengthening because they were too tight. So the strength, some amount of strength training is important, but it's not like bench pressing and squatting. It's like keeping your walking muscles working, your gluteal muscles, your abductors, and all those sorts of things. So. And it's actually not plenty that have stopped because of tightness, because we keep you from getting tight. But you know what I'm saying. If you had to spend an hour a day, I'd rather you stretch than strength train.
Okay, very cool. All right, and then
my wife has something to say.
Yes. I just think that we're really on par with the flexibility, and they were almost they're exactly where they should be. We would then introduce a little bit of Pilates and a little bit more strengthening because they were already met their goals for flexibility.
Could you hear that?
Pilates.
Yeah. if you're meeting your goals for flexibility and you now have more bandwidth and time and energy, then we'll apply that to strengthening. You got to meet the bar for stretching and flexibility before you put your time into something else.
Thank you guys at the Paley Institute, you guys do a really thorough pre-surgery examination of flexibility just to make sure they can even get it done. What are your thoughts on like clinics that just like sign up, make your deposit, and they schedule your surgery before they even kind of get their hands on you?
So I'm okay with scheduling surgery because the logistics of traveling from another country, getting a visa, finding a place to live, I have no problem putting you on the books.
Yeah.
We do ask screening questions. Do you smoke? And let's talk about that. No smoking, no vaping. Don't lie about it. Don't kid yourself about it. If you're putting harmful chemicals into your lung, whatever it's called, doesn't matter to me, you have risk of anesthesia complications. You need to stop doing it. You need to get out of your system. 3 months is better than 1 month, but you cannot take harmful things into your lung. One, it can kill you because of anesthesia complications. Two, it can give you cancer down the road. But all of those chemicals can also inhibit and slow bone healing. So anything, vaping, electronic pens, I don't care what it is. Don't do it. Stop it. You don't need it. Okay. So I have no problem with someone booking a surgery as a placeholder, and then you fly in and we evaluate you. There's no guarantee you're going to do the surgery. But again, if you're going through the time and expense, you're going to put a deposit down. You're going to pay a lot of money for your surgery. You're going to buy a ticket, rent a place. Probably all things are going to be on board. But our team has a screening questionnaire, and we ask you. And I sure hope you're not showing up in Florida without reading and watching and understanding what you're getting yourself into. Because if you are, you're doing yourself a disservice. This is not to be taken lightly. This is real surgery with real potential complications. This is completely elective. There's no compelling need to do this except for your own internal drive. This isn't going to fix something that's broken and life-threatening, but it could be potentially life-threatening. God, let's hope it never is. But really, I can't say that enough. Do not take this lightly. Just because it can be done doesn't mean it should be done. Just because we're having a forum and the 3 people here are very happy with this, bad things happen, even in the best hands. So please do your homework and due diligence and know what you're getting yourself into. This really has to be affecting you to do this.
Absolutely. Okay. Absolutely. Awesome. Yeah. So there we go. Saying thank you. But real quick, I actually want to kind of get Brett and SG and maybe Rio if he's here. You guys' take for any prospective patients who are watching right now, considering limb lengthening with, let's say, Dr. Robbins, and they're saying, should I take the plunge and go ahead and do this? What kind of advice can you give them, Brett?
Yeah, I would just say be very smart and take the time to evaluate everything you're looking into. And if you do that and you really want to do it, then, go into it 100%. Like Dr. Robbins said, you can't think you're just going to show up and this is just going to happen and you don't have to really try, So
that's awesome. Very cool. SG?
I think that this procedure changed lives. I mean, it's when you have the high dysphoria. I mean, it's bad for your mind, for your mental health. So this changed all that, but it's a serious process, a serious procedure. So it means if you have the time and you are full committed, do your research, educate, learn. And do your research, and if you make the right choice, you will get the best results, and you'll be very happy with the result.
That's awesome. Great to hear. And then Rio,
thank you. Yeah. Thank you for saying height dysphoria. So I'm glad you said that because we didn't talk a lot on the mental health aspects. And Victor, you should write this down as a topic. We'll have a whole separate 10 or 15 on mental health aspects. So who's the ideal patient to have this is someone who is affected by their height. And I'll leave that sort of open-ended. You think about it too much. Your perception of your height is what counts here. It's not what other people tell you. So, and it's not the number. You could be 5'10" and have height dysphoria. You could be 5'2" and not have height dysphoria. Plenty of people on both extremes. So the people who are doing this, vast majority are affected by their height in some way or other. And we call it either height dysphoria or height neurosis. This is a type of a body dysmorphic or body image disorder. This is not depression. This is not a psychologically classifiable thing that's a psychiatric disorder. Let's be clear. These are very different. This is not designed to treat a psychiatric disorder. This is a treatment for someone who is fixated or having this neurosis about their height. And when their height changes, by and large, this goes away. And it's really cool. And it doesn't go away because you reach your goal of 8 centimeters, 6.5. The vast majority of patients, they may be sad they only got 5.5 and they really wanted 7. But when they go home and return to the friends and family, if you ask them, they're going to be happy. It's not a certain amount. It's the fact that you are intervening and doing something like, aha, I've taken charge of this thing that has bothered me in whatever capacity, and I'm doing something about it actively, and that's a pretty cool thing. And I think
absolutely. I love that. We're going to definitely do a discussion on the mental aspect of this whole thing, because there's not enough content out there on that, and I think that this is that's a major thing for this whole surgery. Stature lengthening is mental. So very cool. This last question here from Cora, she's saying, do you accept any more doctors for your residency programs or fellowship programs at the center?
We're not a teaching hospital. We don't have a residency program.
Okay.
With that being said, we do have physicians from all over the world who come visit either as just observers for a few days, or even as a scrubbed observer where they have credentials to be in the operating room and watch us do things. You can get in touch with Angelique about that, and then she'll pass you to another one of our colleagues named Sarah Ziegler. But on any given year, I bet we have 50 to 100 surgeons come, not just for stature lengthening. It's, we do a lot more than that. But we do some training in a lot of surgeons' lives, but we don't have a formal residency program.
Gotcha. Very cool. And I have to introduce the famous Angelique Keller on stream. Angelique, welcome to the show. I'm so sorry I saw you popping in and out here and there, but welcome. Can you hear us?
Hi, thank you.
Oh, you can hear you loud and clear.
Yes, I can. Can you hear me?
So yes, we can. So everybody, I want to
such
introduce you to
technical difficulty here.
Yeah, no, we can hear you. This lady has, I've met her when I went to West Palm, and she is literally on top of everything from A to Z. When you come in, she's super, just really, really nice and everything like that. But what she really does is keep the whole team working together smoothly. Now, Angelique, I actually had a question earlier about the Abu Dhabi and the Poland clinics. Now, you have more information on that. So you guys are taking stature patients there. You kind of mentioned in the chat here, I saw it. So you want to speak a little bit more about that real quick?
Oh, yes, definitely. We offer stature lengthening in Abu Dhabi and Poland. We have been done that since their opening. And we have had a patient already finished lengthening and going home from there with great feedback. So if anybody need help with arrange those consultations and surgery, you're welcome to contact me. I can definitely help. And they have great services over there as well.
Very cool. And as you guys
and Dr. Paley will go to each location about 4 times a year to do surgery.
4 times a year. Gotcha.
And we're hopeful with this in place, we're hopeful I am doing that as well.
Okay, look at that. He's going abroad. Dr. Robbins
we'll see. We'll see. It's sort of a supply and demand thing, and somebody has to stay home and take care of the other patients. So.
There you go. That's so true. Yeah. Oh, we only can pick one of the other 25 surgeons. I mean, come on.
That's right.
All right, last question. This just popped in here, and then we're going to do our outro. This was for you, Dr. Robbins. He says, does Dr. Robbins know a doctor that handles thoracic outlet syndrome for patients? I had it done, and I'm having serious nerve problems or damage from it.
So unfortunately, I don't. So thoracic outlet syndrome, it also depends on where you live. It's a rare thing. It's we say it's kind of easy to diagnose. You do these maneuvers and you get these problems, but you really want to go to the person or persons who do this a lot. And maybe that's where you went to and you're just having an atypical outcome. This is definitely the kind of thing that you want to get on the internet, which is very easy to do nowadays, and Google, where's a thoracic, like where the limb lengthening and stature and congenital problem place on the earth, and you found us here. You can certainly find that other niche practice that does thoracic outlet syndrome. I'm sorry you're having this problem, but it's important to know, are you having an atypical problem because something went wrong, or are you having a typical problem and the expectation is that it's going to get better? And this is way out of my scope, so I would absolutely refer you to getting online and reaching out. I'm positive there is a center somewhere in the world who would do a virtual visit with you and give you knowledge just like I am, because that's what we're all about. We're trying to offer the best care for patients to have a choice.
That's right. You guys do it Extraordinarily well, guys. I want to. This is amazing. I mean, we have just hit our milestone with our 100th episode. I mean, we kicked it off with the man who started it all, Dr. Robbins. I mean, the bone magician himself is here. It's incredible. But really, this milestone episode is also about you guys, you prospective patients, you dedicated viewers who have engaged week after week this journey, this discovery and learning. I'm super grateful for all you guys and your continued support. After all, it's all your questions, your curiosity, your engagement that's made this journey, like, truly special. So from Cyborg for Life, I want to thank every single one of you guys for watching, asking these amazing questions. Dr. Robbins, for your time. I mean, over 2.5 hours sitting down, answering patients' questions in this amazing presentation. We're reminded that like knowledge is going to be the thing that kind of helps. It's the beacon of progress, right? It's going to help us to expand our understanding of limb lengthening and bring awareness to the world. So guys, I want to thank every single one of you guys. Brett, Rio, we have SG on here. Angelique, thanks so much for helping out. Lena, you've been here the whole entire time. Everybody watching the chat. Somebody said something. I'm sorry. All you patients watching from around the world. I know you guys, different time zones. You can watch the replay. It's going to be up on the channel 24/7. And so if you guys want to reach out to the Paley Institute to book consultations, you can go to limblenthening.org, as you see in the ticker there at the bottom, or just email Angelique here. She's happily answering emails every single day, all day. akeller@paleyinstitute.org. And as far as the PRECICE Max nails go, you guys can still book your surgeries for them. They will keep your deposit and schedule you as soon as they get the nail. Okay, so you can do that. I know a ton of you guys have consulted with me, emailed me, DM me, everything like that. The Paley Institute is the clinic that is going to be the first to implant it. We're going to have Dr. Paley come on in the next 6 to 8 weeks when the nail is ready to come out. And he's going to do a big episode on that. So be sure to stay tuned on that. And guys, you can also email Dr. Robbins and say thank you so much. And all of that. It's crobbins@paleyinstitute.org.
Yeah.
So
and if you have questions for me, you send them to Angelique or Limb Lengthening, and they'll get forwarded to me. But yeah, if you want, you're welcome to post my email anywhere you want.
Awesome. Very cool. Well, thank you guys for watching. That is episode 100 of Limb Lengthening Live. Let's give it up for Dr. Craig Robbins.
That's funny.
Rio, Brett, everybody here. And until next time, this is Victor from Cyborg for Life signing out. See you guys next time. Bye. Have a good night.